I've just started the recording of this CAC meeting, and in compliance with CMS, for the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the CAC meeting and consented on behalf of the Palmetto GBA. With that being said, I'm going to go ahead and begin the meeting. We do have an agenda, and the first thing I'd like to start with is some introductions. As far as the introductions, if you can keep it brief, just tell me a little bit about yourself, and I'll announce the panelists. Just tell me a little bit about yourself and your background and your education, and that'll be sufficient. When we actually begin the question session, I would ask that the experts, you've all received the questions ahead of time, that feel, what I'll do is I'll say the question and then have go in order and allow you to respond to it. Please try to keep your responses to 1 to 2 minutes, because we have plenty of questions to go through that we need to get through. And then at the end, if we have additional time, which we should have, we'll have a little bit of further discussion as far as some of the previous topics or some additional thoughts that I have on the matter. That being said, I would also like to introduce who else is here with me. We have our Senior Medical Director and our head, Dr. Shane Mull, and then 2 other contractor medical directors here, Dr. Jennifer Abrams and Dr. Judith Volker. And then I'm Dr. Scott Trimas, and I will be leading the session. Getting started, and then this is in no particular order. I'm just going to announce the particular people that have agreed to be panelists for the as subject matter experts. So let's start with Dr. Howard Rogers, if you'll just say something about yourself and your background.
I am a general dermatologist and Mohs surgeon, and I also am a dermatology representative at the RUC. I have taken part in numerous of the cost measured developments for both dermatology and cancer in general.
All right, let's go on to Dr. Scott Collins.
That's me. I hope I win the award. I'm from Portland, Oregon, for the person who flew along. I knew service. I was supposed to be here yesterday. I'm a dermatologist and Mohs surgeon as well. I am the American Academy of Dermatology's representative to the RUC, so I'm a panelist there. I, with Howard, have worked on a lot of cost measures with CMS and other contractors, and then heavily developed, or am also heavily involved in large database development for dermatology and Mohs surgery.
So next panelist is Dr. Brett Coldiron, and I apologize if I'm saying your name incorrectly.
You said it correctly. Brett Coldiron, I'm from Cincinnati, Ohio. I'm a dermatologist, and I practice Mohs surgery there, and my wife is a general dermatologist there as well. I am past president of the American College of Mohs Surgery, past president of the American Academy of Dermatology, and I served on the AMA RUC Relative Value Update Committee for 17 years before I handed it off to my better partners here.
Right. And next, Dr. Dole Baker.
Dole Baker, I'm a board certified otolaryngologist, facial plastic surgeon. I'm a private practice in Anderson, South Carolina.
Right. Dr. James Bates.
I am a radiation oncologist at Emory University, specializing in head and neck cancers.
Dr. Stuart Burry.
Hey, I'm Stuart Burry. I'm a radiation oncologist. I'm the chairman of radiation for the Atrium System in Charlotte. Glad to be here. Thanks for having us.
And I think Dr. Ramori just joined us.
Hi. I am Amar Rivari, and I'm the chief of radiation oncology at Lumis Health in Annapolis. And background-wise, I'm the RUC advisor for ASHRO for radiation oncology and also chair our health policy committee.
Dr. Brandon Coakley.
I'm a board certified dermatologist and Mohs surgeon in private practice here in Little Beach, South Carolina.
Thank you.
We offer both radiation therapy for our patients and Mohs surgery.
All right. Dr. and I'm sorry if I butchered this, Dr. Bisham Chera.
Hi, hey, I'm Bisham Chera. I'm also a radiation oncologist. I practice at Medical University of South Carolina. My specialty is head and neck cancer, skin cancer, and I'm part of the ASHRO Health Policy Committee and Co-Development Evaluation Committee.
All right, so we're going to go ahead and get started here in just a minute. I just wanted to lay a couple of ground rules. As far as the meeting is concerned, we're going to limit our discussion to just the SMEs. Everyone else is welcome to listen in, of course, but we're going to keep our comments just to the subject matter experts to answer these questions. And that would, and again, that's so that we can get through all the questions as we have there on the submitted to you previously and that are available for review online. All right, so the first question, and the way I'm going to ask the questions, and I'll just kind of look towards a side, and then if you want to answer the question, you go ahead and answer the question. Some questions may be more pertinent to specifically radiation oncologists, some patients may be more pertinent to dermatologists, maybe more pertinent to plastics. And so as the questions come out, you don't have to answer every single question. So it's not meant for everybody to answer every question. Does that make sense? All right. So I'm going to start with the first question. So the first question, and this is predominantly for the radiation oncologist, although if a dermatologist would like to answer this as well, we can do that. But let's start with what are the major similarities and differences between superficial radiation therapy and electron beam therapy. So we can start with one of the radiation oncologists. Who wants to step up first? I'm looking at this side here. Or how about right here? How about that?
I mean, I guess there are a lot of similarities there, both superficial ways of giving radiation that are highly effective in the treatment of skin cancers.
If we can maybe a little bit more detail with if there are more specific differences, so we go to the next radiation oncologist.
Yeah, so, they're both different types of radiation, electrons or electron radiation, electron beam therapy, and then superficial therapy is at low energy photons. And so there's some technical differences in how big your target volume should be. There's some shielding considerations that are different. For superficial, you don't need to have a lot of tertiary collimation. You can use just a cone to form the beam. Then for electrons, the temperature is a little bit different. So typically your area that you're treating should be a little bit larger than if you're using when you're using superficial. And then there's also additional shielding requirements that are needed for electrons.
I think overall, the big picture is that they're pretty much a radiation oncologist could do either historically. All our radiation oncologists back in the 70s, 80s, we used to have these superficial radiation therapy machines with KV X-rays, but the linear accelerators are capable of producing both the high energy photons as well as using the electrons. So just as a matter of convenience, most of our clinics felt we would use those linear accelerators. So most of our treatments all shifted to electron therapy rather than doing KV therapy, rather than having a separate machine to deliver it. But principles of dosimetry and how it's treated and everything is the same in terms of they're both very superficial treatments.
Anybody else want to make any other comments now? So one of the things that during this conversation, we'd like to try to limit in our talks to things that are supported by the literature. So we really want to have literature based as opposed to, I know some of you all have vast amounts of experience and that's fine, but I'd really like to limit the talks to what's actually out there. I mean, you can briefly mention something to the effect, but we're trying to focus on things that are the literature that supports, various treatment options. So on the second question, is there any literature to support one modality over the other in terms of cure rates, complications, and long-term sequelae? Now, from what I understand, electron beam therapy, as you said as well, as one of the panelists said, is that it's really kind of a form of superficial radiation therapy. Wouldn't you say the electron beam therapy is actually a form of, or electronic brachytherapy, a form of superficial radiation therapy? They're both designed to be superficial. From what I read with the electron, the machines that are out there for electron brachytherapy, is that they're using, in their schemes, they tend to use more hyperfraction at higher doses for shorter periods of time, and then more the superficial is using lower doses for a little bit longer period of time. And then also, from what I've read for the electronic brachytherapy, is that they're also using photons as part of their treatment option in the machines that they're doing. So both are actually using photons. Am I not correct in that?
So I think one of the terminology we want to probably understand here is, are we using EBT to refer to electron beam therapy?
Electronic brachytherapy.
So electronic brachytherapy is very different than electron beam
Yes.
therapy. Electronic brachytherapy is a relatively new procedure, which is why it has Category 3 codes associated with it. It's still considered investigational, and it does use higher fractions with a direct source providing photons to the area at target. But that is something that's what we were talking about as radiation oncologists, is electron beam therapy, which is the common modality radiation oncologists use to treat skin cancer.
Right. Well, what we're trying to include in this, we know that electron beam therapy is also been used for many, many years. And electronic brachytherapy is another form of superficial radiation therapy, in essence, because it's superficial treating. And so we're trying to make sure that we include all aspects of that in this discussion. So I don't want to limit it to one source, but we're trying to make a determination, and that's why we're having a local, this meeting is to make that, to help assist us in making that determination. So for the next question, as we were going to talk about, if you were to compare the modalities, the different radiation therapy modalities, is any one superior to the other, whether it be superficial radiation therapy, or electronic brachytherapy? Is there anything?
If we're talking about literature, like I
Yes.
said, so because electronic brachytherapy had only been approved for category 3 codes, at the time it's been extended once, the literature did not rise to the level to support a category 1 code. While for superficial radiation therapy, which is associated with code 77401, for low energy photons and our electron codes, those are supported by literature to support a category 1 code. So electron beam radiation therapy and superficial radiation therapy with low energy photons do have literature, and I personally don't know any literature that distinguishes any survival or cure rates between them. And I'm curious to know if the other radiation oncologists, but electronic brachytherapy, the literature does not rise to that level yet. So it's potentially there will be category 1 codes as the literature has been maturing, but right now we're not there.
Okay, and that's part of that's part of what we're looking at. We want to see what's out there and what's available treatment options as far as cure rates, sequela, and then options for patients as far as reasonable and necessary treatments for patients. Anybody else want to make any other comments on that before we move to the?
I would just agree, there's no real randomized evidence comparing electron beam therapy versus superficial X-rays. Both are excellent treatments with very high cure rates and relatively low long-term sequelae.
Yeah, can I ask a question? I'm sorry for being a little bit late. I just came from a brachy case actually in the OR. I'm Jake Scott. I'm a radiation oncologist. For the purpose of this meeting, can we define the difference specifically between electronic brachytherapy and low energy photon? Because I think in a lot of senses, those are similar. I mean, SRT is different than electronic brachy, but can we define electronic brachy in terms of this conversation, please?
Yeah, we'll go ahead and do that, but there's no further participation from outside questions. So this is just.
Apologies.
So with that being said, I think it's fairly clear from what unless you want to mention further the differences between electronic brachytherapy and I understand the difference between electronic beam therapy, electronic brachytherapy, and superficial radiation therapy, of which really electronic brachytherapy is kind of a subset of superficial radiation therapy.
Can I just make a clarifying point? Sort of 3 categories of radiation we're talking about. Just make sure we're calling them all the same thing.
Yeah.
Superficial radiation, which is low energy X-rays. Electron beam, which is electrons from the machine. Electronic brachytherapy. So perhaps we can call electronic brachytherapy for purposes of this conversation. Sure. We keep getting ourselves confused. I'm confused.
Sure.
And all 3 of those are a category of superficial radiation. So maybe we should call it X-rays, electrons, and brachytherapy, and superficial is the broad category. So we at least are all.
That's fine. If I fail to mention that, or I forget to mention that, we'll make sure that's understood. How's that? All right. So let's go on to what we want to go for. Go ahead.
But just a comment on that, comparing one modality over the other, there is literature, retrospective, I agree, no prospective studies that I'm aware of, but there's literature retrospectively looking at SRT versus image-guided SRT. There were 3 different studies that were used. It was by Dr. Yu in Cancer Discovery and Oncology in 2022, demonstrating a superior cure rate for the image-guided modality versus standard SRT.
Yeah, we're going to get into a little bit of that later on as far as the image guidance utility in treatments. All right, so question number 3. Based upon the peer-reviewed literature and societal guidelines, which would you consider first-line therapy, second-line therapy, and not indicated for the following? So let's start with primary squamous cell of the skin in easily removable areas. So let's start with this case with the dermatologist, with facial plastic surgeon, and then we'll move on to the dermatologist.
Primary squamous cell carcinoma, easily removable area, primarily be treated with surgery.
Yeah, primary squamous cell carcinoma on the easily removable area is a highly heterogeneous disease process, from the smallest squamous cell carcinoma in situ up to a deeply invasive squamous cell carcinoma down to underlying structures. And so, in terms of primary treatments, We are dealing with multiple different surgical treatments, from Mohs surgery to excision to shave removal to destructions. For the least aggressive ones, topical therapies like topical 5-FU or Miclomod have been shown to be effective.
Yeah, the only thing I'd add is if the NCCN guidelines are a good place to look at widely reviewed, vetted things, and the version 1 2024 is actually available now. I just pulled it up. And it parrots everything that Howard said, with the only addition is it does say radiation therapy for patients declining surgery. So I think in general, that declining surgery is probably where a lot of this is going to hinge on. You know, is it patient preference? Is it patient morbidity factors that prevent utilization of the more longly established surgical modalities?
Yeah, I'd say surgery of one kind or another could be curettage, electrodesiccation, it could be an excision, no surgery, it could be as long as you're removing the tumor. And at some point, we're going to need to define the patients who are not surgical candidates. And I don't think we've done that yet, but at some point, and they may be candidates for radiation.
All right. Let's head over. Go ahead.
I agree with what the other dermatologist group said. There's a dozen different ways to treat squamous cell carcinomas. It depends on size, depth, tumor histology, and the unique patient. So comorbidities has been suggested. Patients that are surgical candidates or refuse surgery play into that. The location, it's tough to answer with one first-line therapy for the all-encompassing category of squamous cells.
Yeah, and I would agree with everything they said. The only other caveat beside patients who are not eligible for surgery, and this probably goes to your point about which candidates are surgical candidates, would be in terms of location on the face. We define an H zone. And so skin cancers in the H zone oftentimes are usually referred for radiation therapy because they're not felt to be the best candidates for surgery, but I was let the dermatologist speak.
Yeah, and if I can clarify that, you know, the H zone encompasses areas like the cheek, which are incredibly amenable to surgical intervention. You know, nasal alar rim, eyelid margin, other places are still very amenable to surgical therapy, but the reconstructive efforts become more complicated in those cases. So even within the common 3 zones, I agree with what you say, even within the common 3 zones, there's nuance within those zones.
And we have that as a further question on the
Sensitive location.
Yes, exactly. So any other additional colleagues want to make some comments?
I mean, I think it's pretty straightforward to me that a easily removable area, primary squam or basal cell, the first line recommendation is surgical resection. And if patients are not amenable to surgery, radiation is a second line option.
I just commented the AAD's guidelines that were published in 2017 and 2018 support that the majority of these tumors can be treated with surgery, but the radiation is an effective option for patients that are not candidates or decline.
All right. And everybody, just to get on there, the patients that decline, is that just saying if the patient says, well, I want to have radiation instead of it, that should be an acceptable alternative? You know, patient says they have a basal cell on their cheek, small one, or squamous cell on their cheek, 5 millimeters or so. Should they be allowed to just go ahead and say, I prefer radiation?
I can answer that. I mean, I have patients that come to me had like 10 moves. They don't want to have that. You know, there's some morbidity in surgery, especially if you've had a lot. So sometimes patients just don't want to go through the Mohs procedure.
Okay.
Well, radiation is a highly effective therapy. It's not like it's a class B. Right. The surgery is an excellent therapy, easily accessible.
My question really is not so much we know it's effective. We know it's going to be effective, but I'll use the analogy. It's like taking if you're going to light a candle with a match, but you can also light a candle with a flamethrower. You're going to take the flamethrower to a 5 millimeter basal cell on the cheek or a squamous cell on the cheek. So I said, is that reasonable and necessary?
I would say radiation is akin to like one of those electronic butane lighters.
Yeah. Okay.
They're highly effective, highly localized therapies that can produce excellent rates of cure with relatively low long-term side effects.
Okay.
And the one thing I'd add to that, just to broaden the discussion a little bit, you know, if you have somebody with a small basal or squamous cell they're essentially interchangeable at this level. On the cheek, and they're 32 years old, and they're surgery resistant. But you have to think about, the older literature, which supports the risk of secondary tumor formation 20 plus years down the road, the late stage fibrosis telangiectasia that can occur in previously radiated areas. And with the newer technology, we don't have that length of follow-up. And then the challenge is, most people who form non-melanoma skin cancer form more than one. And so then if you look at the difficulty of subsequent treatment in a prior radiated area, that becomes an issue. So in somebody who's 80, it's a different calculus, at least in my mind, than somebody who's 35 in terms of preference. No morbidities, no anything else. Somebody walks in and says, I don't want a knife. Then the counseling depends on a whole bunch of different things, at least in my mind.
And I think that to follow on that, to force someone against their will to have surgery for a curative therapy that they could have in a different way. I think surgery is the preferred choice, but I'm not going to refuse to radiate someone and refuse to have surgery. It's not irrational.
All right, so I think if we're all in agreement, there's really no reason to discuss B, primary basal cell, because we know if it's acceptable for, what the options are we just discussed for primary squamous cell. They should be more than acceptable for primary basal cell. I think parents probably agree with that one. So let's move on to primary squamous cell in sensitive locations. As we mentioned earlier, H locations, ear, nose, eyelid margins, things like that, pretibial areas. So why don't we start, in this case, we'll just reverse with the radiation oncologist. Based on the literature, what would you consider first-line therapy, second-line therapy for primary squamous cell? Let's go ahead and include basal cell as well in sensitive locations that I just mentioned.
Yeah, so for me, I would sort of consider both primaries. The main decider being the cosmetic outcome of the situation. Let's say it's the tip of the ear and you have to have a wedge resection of your ear versus radiation. There's a cosmetic difference in that. So that might lean you to radiation. Those situations where surgery is preferred. So I think that's a more of a balanced discussion between the two, particularly again for me that cosmetic consequences of surgery.
All right. Anybody else on this side want to make a comment?
Yeah, I think sensitive areas, H zone, particularly of the face, they should be considered, equal options for a patient. I know that our reconstructive surgeries have gotten very sophisticated now, but they can take multiple reconstructions depending on how bad the cosmetic defect is. So in some ways, it's radiation is actually less invasive and maybe more cost effective for certain, tumors where you have to reconstruct.
Forehead flap to the nose. Yeah.
But I do think it's very hard to define a priori what these situations are. Each skin cancer in the H zone is a different beast, and I think there's value to multidisciplinary consultation in this setting.
Okay. Now let's go ahead and okay, a dermatologist and plastics.
So just to enter in the record, if you look at the NCCN guidelines, they differ between low risk and high risk, and I'm scrolling and I'm probably going to not find it quickly. High risk, if you look at the high risk guidelines, it's Mohs or some type of OR-based complete circumferential margin assessment, or a standard excision with not necessarily frozen section margin assessment. And the NCCN guidelines state for non-surgical candidates, consider multidisciplinary consultation and discussion of definitive radiation therapy. And if you look at the definition in NCCN of high-risk tumors, those include any tumors in sensitive areas, plus bigger tumors in non-sensitive areas and things like that. So at least this is indicating, based on the literature that was reviewed to establish these guidelines, that radiation therapy is a second-line choice. I personally would say that I think that it's probably the scope might be a little broader than that, but just looking at what the NCCN says, that's what they say.
So, when you look at H-zone tumors or tumors in sensitive locations, they tend to be highly unpredictable in terms of their biological behavior. They have high recurrence rates, not just because they're unpredictable in terms of their local extension, but because these areas don't have very much skin to play with, right? In terms of the literature, Mohs surgery or surgery with complete margin evaluation is definitely the first line treatment there. And in terms of long-term cosmetic outcomes in these locations, the literature shows fantastic results from surgery.
I would agree. And a lot of it depends upon exactly the size of the tumor in the sensitive location.
All right, so let's go on to the next question, or part of this question. Recurrent squamous cell and recurrent basal cell in sensitive and non-sensitive locations. So if I can get some elucidation on that, that would be helpful. So why don't we start on this side again, and we'll just rotate around. How's that?
For recurrent squamous cell, basal cell carcinoma, frequently there's not much more area left to reconstruct with. And frequently those lesions are treated multimodality.
Yeah, this is highly heterogeneous in terms of, it can be from a small recurrence versus, the incredibly disabling recurrence. I think that the literature indicates that surgery with some sort of a multimodality evaluation is important. I think that in these sort of circumstances, because a lot of times you have unpredictable depth of invasion of these tumors, that a superficial radiation modality.
So I guess part of my question is, and you kind of answered that there, and I'll get it from the radiation oncologist as well, is that in someone who has a recurrence, the primary first-line therapy would likely be surgeries, which are recommending of some sort, plus or minus radiation therapy, depending on the size, location, et cetera.
Yeah, and so back to NCCN again, just briefly, NCCN includes recurrence in high-risk basal cell and squamous cell, and that follows that same paradigm of surgery, Mohs, surgery with margins, with radiation therapy as a second modality. But as Howard said, and has been mentioned, recurrences can be a small side recurrence of a very superficial tumor to something that's deep in the nerves. And so that, a small recurrence where you haven't burned up all of your reconstructive reservoir of tissue, if surgery probably still is number one, where you have burned it up, where you've got perineural involvement, where you have superficial bone invasion, all of those type of things. All of a sudden, you're talking about a multidisciplinary team that, to me, absolutely includes radiation therapy as part of that discussion.
Yeah, when you have a recurrent tumor, you have to get it out. Generally, that's surgery. Now, if you look at the appropriate use criteria for Mohs surgery, which we published, the Academy of Dermatology published a few years ago, you don't need Mohs surgery on a recurrent superficial basal cell. You just need to re-excise it. But you probably need Mohs or some sort of margin control in any other recurrent tumor, because my understanding of radiation is some of it, without, maybe not with this new ultrasound technique, but it's a blind technique. You guess where the margin is and you radiate the margin. And you don't know exactly where that tumor is. And if you have a recurrence, it could be a lot of places.
So when we plan our radiation, especially for many of these larger, complicated, recurrent ones, where sometimes we're even also radiating lymph node chains, we usually do a CT scan in preparation for the radiation. So this way we can see if there's any gross disease, or if we can visualize the treatment thing. So I wouldn't say we're aiming blindly. And to go into a discussion we will have later, the ultrasound doesn't give you any information on that. So it's really from your CT simulation where you can kind of assess the areas you're going to be treating. And typically, in terms of in a recurrent setting, yeah, many times I agree, it's a multidisciplinary thing. You'll talk together as a team. Sometimes they'll get surgery if amenable, and then depending on high-risk features, we will treat. And sometimes we'll include the lymph nodes, sometimes we won't. And we can talk about all these high-risk features later or now. And then the other thing is sometimes though patients who've had recurrent, they can't get reconstruction depending on the location it's in. They're elderly, it's in a location with poor blood supply, and an elderly or diabetic patient or something like that, where you worry about healing a non-healing wound. And so some of those patients are referred to us just for radiation.
All right, going forward, I do have, and you mentioned something, I want to kind of move it along. So if in a recurrence, if it's not amenable to surgery, then radiation is going to be the treatment of choice or adjunctive treatment at least, with partial removal or whatever the case may be. But I guess my question going forward, and part of this is very helpful, is if the tumor is recurrent, whether it's a basal cell or a squamous cell, certainly if it has higher risk factors like sclerosing, et cetera, and we'll get into some of that later. Would you agree that at least some form of surgery would be the first line of therapy followed by radiation, or would you say that you would still prefer radiation? That's what I want to know as a first line treatment.
I mean, as everybody has said, this is a very heterogeneous group. Generally speaking, recurrent skin cancer is more aggressive, typically modality therapy. There are situations where you can just, do definitive radiation, like a recurrent basal cell, that's, in a set cosmetically sensitive area that now, we don't want to cause more cosmetic problems, so you can definitely radiate that. But generally speaking, recurrent skin cancer, particularly squamous, is aggressive. Typically, that's multiple modality, but there are other.
Yeah, but I mean, for like a basal cell, and you mentioned something like that. So in an area that has recurred, obviously it's either a more aggressive basal cell or more, they didn't get the margins the first time or something else happened. It's more likely to recur again. So would you not recommend, are you saying that radiation therapy should be frontline therapy in those cases?
I mean, I'm treating a guy right now that had a basal cell stick with his nose, small one, had, multiple surgeries in the past, keeps coming back, and he doesn't want to have more cosmetic effects.
Okay.
You image the patient, there's no gross tumor, their MRI is negative, that's, to me, the perfect, that's a situation where radiation will probably work. That's what we're doing.
I very much agree with that. And Dr. Coldiron brought up a good point. There's two different types of recurrent tumors. Really staging these keratinocyte carcinomas, the kind of the new term for non-melanoma skin cancer basal squamous, staging them is very appropriate. It's very different to have a recurrent tumor that's recurrent at the deep margin after surgery. Absolutely, that needs aggressive surgical management with possible adjuvant radiation afterwards on top of it. That's different than someone who has a superficial basal cell cancer on their nose that has had multiple rounds of surgery where the recurrence is superficial and broad rather than a deep perineural invasive tumor. And you have to take that into account when you're deciding what's appropriate for a recurrent keratinocyte carcinoma.
Okay, and then I'm gonna go a little further. Then based on the literature, I have not seen, and maybe there is, and to point out what are the long-term success rates using radiation primarily in recurrent basal cells or recurrent squamous cells. I don't see a lot of literature out there that supports that. That's pretty
sure. I'm not aware of a paper that addresses that specific question.
I think it's also a nearly impossible situation to study. What is, you have to really clearly define what recurrence is. A lot of the recurrent tumors that get sent for radiation are much more what Dr. Chera talks about, failed after multiple surgical recurrences, or what our dermatology colleagues have talked about with very infiltrative or deep or PNI recurrences that are not surgically resectable, essentially.
Anybody else want to add anything else? Okay. All right. I think we can skip the next one, squamous cell with perineural perivascular extension. I think we would all agree, obviously, if that's the case, it's going to be some sort of multimodality treatment. I think that'd be a good consensus, or at least surgery is the first option. Would you agree with that? Okay. The panelists, the SME panelists agree with that? Okay. All right. What about other malignant neoplasm of the skin excluding melanoma, such as eccrine carcinoma or sebaceous carcinoma or adenoid cystic carcinoma? Is there any literature to support one treatment modality over the other? Because we're really talking mainly the majority of them obviously are basal cell and squamous cell. But what about such things as, eccrine, adenoid cystic? I don't want to mention Merkel cell because that's a whole different entity in and of itself. But those other ones that are typically done with surgical excision or Mohs procedure. What about radiation as a first line therapy for those? Any thoughts on that at all?
Yeah, I mean, it's all retrospective papers. They typically considered, well, depending on which paper you read, most literature said those are more aggressive. Usually that's, surgery and post-op radiation, like eccrine, sebaceous.
Adenoid cystic will follow that nerve back into the base of the skull.
The only clarification I would make, and I know it's outside the scope of this, are cutaneous T-cell lymphomas, which are a primary radiation and
correct. Yes. Yeah, and I was totally excluded, but I agree with you. I think the consensus is there for that. All right. Go ahead.
Dylan, again, a tumor you didn't mention is DFSP, dermatofibrosarcoma protuberans, where there is good literature albeit mostly retrospective on complete margin assessment and Mohs especially being excellent for that tumor and radiation not playing as much of a role in that specific tumor.
Okay, would radiation oncologists agree with that or not?
Well,
Since he brought it up, we need to go ahead and at least conclude another perspective.
Your opinion, go ahead.
I mean, big, a huge DFSP on the scalp, that's surgery. Typically, we would do post-op radiation for that. I mean, I guess it's small DFSPs that you catch with the Mohs, it's different, depends again.
I think the problem with this conversation is everything is it depends. I mean, it's like, it's not us and them, it's us and us.
Yeah.
Like we're
No, I
working on these together and figure out the best treatment for patients.
And that's understandable, and that's the purpose of this, is really to pour forth the information to help us decide, and it's not just obviously me making a decision, it's the other contractor medical directors, and with input from the literature and from you all, that will help us to make this decision to benefit patients.
There is good literature, retrospective literature backing Mohs surgery for DFSP, but I'm not aware of the same sort of retrospective literature for radiation.
There is.
Yeah.
There is that.
I mean, I think the bottom line is like, for these complex ones, if you're eventually trying to create an LCD, I would say it should say something about a multidisciplinary discussion.
Yeah.
For treatment planning.
Okay.
So given that this LCD is about SRT and electronic brachytherapy, would you guys agree that DFSP is not amenable to these superficial types of radiation?
Oh, yeah, that's a good point. Yep.
Yeah.
Most of these things,
Clarify that.
Yeah.
State.
most of these things are not amenable to either of those therapies.
Okay, I just want to make sure we don't need to include additional lesion types and things like that on this LCD, and that's part of the reason why I brought that up. That's why that question came up to begin with.
Right.
So the primary focus is going to be for basal cells and squamous cells.
Well, I would clarify
Or
that
they
they
explain
might
themselves.
require confusions with nomenclature. Many of these are amenable to electron radiotherapy from a linear accelerator, especially for small lesions that are not wildly deep.
So I would say for a lot of these rare tumors, it's adnexal tumors, non-BCC, SCC, melanoma cancers, surgery is the primary consideration, and there is not literature support for superficial brains radiation.
Right, and so and back to the point that was made about the 3 types of radiation. When in an LCD, superficial radiation therapy should not encompass all this. Electron beam radiation therapy delivered by a linear accelerator is separate. And so superficial radiation therapy and electronic brachytherapy are the ones that are only for very small select things. Electron beam radiation therapy is for all this.
Right, now I understand, and that's why we're limiting this to the topics that we're talking about.
Yeah, it's just because when you had mentioned before that SRT is the broad category and these are 3 subcategories under it, I would disagree with that. Electron beam radiation therapy should not be brought in the same LCD as SRT.
I think we were answering the question as radiation oncologists. Can we use radiation to treat this problem? Not which tool would we use? And so I probably need to reframe our answers with understanding that part of the question is what tool are we
Correct.
using?
That's correct. That's what we're doing. There is obviously a large usage now of superficial radiation therapy, and I'm not saying it's not indicated, but there's a large usage for non-melanoma skin cancers. And so we're trying to ascertain whether or not this is, a good, reasonable, and necessary treatment for beneficiaries, and that's the purpose of this. And so, the SRT, which includes electronic brachytherapy as a superficial modality, and then the traditional treatments of Mohs dermatology, we're trying to ascertain, the best treatment options available for patients.
Right, just
Electronic beam therapy is a separate, we have an LCD on electronic beam therapy. Okay, so that's not what we're discussing at this point, if that makes sense. All right,
so those our answers would be different.
Exactly.
Yes.
Yeah.
Just so
Okay.
you're aware.
I would say that superficial radiation as defined as either electron brachy or low energy X-rays, the only one of those situations where I would think that it is a reasonable choice are de novo skin cancers in the second line to surgery setting. And actually, I would probably say second line to both surgery and like linear accelerator-based electron radiation therapy.
Would you feel that superficial radiation therapy and electronic brachytherapy would be appropriate for recurrent tumors?
No.
I think that's important.
Is there anybody else, like Dr. Costa, do you feel differently?
It depends on why it's recurrent. I very much agree for deep recurrences or you have to look at the staging. Is this a well-differentiated squamous cell or a poorly differentiated squamous cell? The literature clearly shows a difference in behavior based on those types. And there's a difference between somebody who had a well-differentiated squamous cell with a peripheral squamous situ recurrence and somebody that has a poorly differentiated squamous cell with a lump under the surgical site. Those are not the same. Superficial radiation therapy should not be used for deep recurrences for aggressive tumors.
Okay. And that's part of what we're trying to ascertain. We know the indications in general. We have an LCD on radiotherapy. We have an LCD on Mohs. That's been long established. It's been reviewed. That's been put up for comment. That's been accepted by astro and radiation oncologists. And then we have the Mohs that's been accepted by Mohs and dermatologists. So the purpose of this meeting is really, and maybe I wasn't clear enough, but I want to make sure it's clear. We know electronic beam therapy, traditional linear accelerators, et cetera. We know that the treatment options for that. We're trying to make sure that we have the proper indications for beneficiaries that are reasonable and necessary, including the use of ultrasound guidance, which we'll get to in a little bit. And that's why we have you all as experts, because you all are the experts in this area to discuss.
So if we can just scroll back up to, what's it, question 3?
Yep.
So just go a little higher. So I really think we're talking about group B would really be the indication for SRT, potentially some subset of group A. That's really it.
And that would include image guidance, which we'll get to later, or ultrasound.
We'll just about image guidance.
No, it's a preview. I would agree about B. I would say that there's published literature for A through D for SRT.
Okay.
That's why a lot of follow-up in retrospective studies.
Okay, and that's why we're having that's why we're having a discussion and having you all as experts to help do that. Okay, so let's go on a little bit further and go into question number 4 now. And this is specifically asking for this, so it's not we don't really need a long answer to this one, but are there, and part of this is based upon what I've been able to find and what the other contractor medical directors been able to find in the literature. Are there any randomized clinical trials on the use of SRT, again, we're limited to superficial radiation therapy, and electronic brachytherapy comparing treatment results and complications with Mohs surgical excision? So let's start on this side. Right, sir.
I'm not aware of it.
Not aware. Okay.
No.
So-
Did you guys find some that we don't know about?
No. Yeah, exactly. The other medical directors are now full of it, and we can do it. I've done PubMed and Hayes and call Dr. Google if you'd like it, without even prefacing them, or with Dr. Yahoo and all the other ones out there. But I have not been able to find this, nor have any of my colleagues. That's the reason why I asked.
It's really impossible to run a clinical trial to compare these two.
And I believe
The number needed to treat and cost would be astronomical. I think that for easily accessible de novo lesions, there's a consensus already based on lots of retrospective data that both are good treatment options.
Okay, excellent. Thank you.
Those patients won't be randomized between surgery and radiation. Patients don't want that randomization. They want to pick one or the other.
And I think comparison of published retrospective reviews of these two modalities would be an apples to oranges comparison because different tumors are being treated.
Okay.
And I would say generally comparison of retrospective reviews in this setting from two separate sources of data is very fraught with bias, given how little information is often reported regarding other histologic factors that may influence recurrence.
All right. So let's move on to the next question. Question 5, and this is where we really need your input as well. According to the NCCN guidelines, the recommended treatment for uncomplicated non-melanoma skin cancers includes primarily Mohs excision and/or simple surgical excision. Is there any peer-reviewed literature or societal guidelines that recommends SRT or EBT over Mohs excision or traditional excisions for basal cell or squamous cell. I'm realizing there's some heterogeneity to this and what goes, but if I can get some input from you all. And so if not, then what limitations should be placed on implementation to use over first-line therapy? And if so, then when and under what circumstances should SRT or EBT be utilized over traditional excision or Mohs surgery? I know some of you mentioned it earlier, patient selection or patient choice, but if we can go into a little bit of detail, and let's start on this side of the room.
And just remember, EBT is the brachytherapy.
The electronic brachytherapy, exactly, yes. Yeah, we're not disputing electronic beam therapy as excellent treatment option for those. We're limiting it to this for this part. Dr. Baker, is there anything you want to add to that?
No, I think the primary treatment would certainly be surgery.
So the crux of the question seems to be A, right? Because we do understand that there aren't any sort of guidelines, to my knowledge, that are going to favor one or the other. And so, you know, what exactly constitutes a non-surgical candidate? How much effort needs to be placed into the educational process to have a person fully understand the ramifications of not having surgery and not having a established negative margin? These are difficult questions that I think the group is going to wrestle with.
Right, and that's why I put that question up there, is because we're trying to got some guidance to help us in developing this LCD so that, you know, we form the reasonable and necessary, you know, indications for patients to be able to choose between SRT and EBT, again, knowing, as Dr. Abrams said, that, you know, limiting it to that versus surgical excision and Mohs excision. And I don't have anything else to add to that.
No, I don't think there's any literature support.
All right, let's start with a radiation therapist and work our way down. How's that?
I don't know any literature supporting it over Mohs or excision.
All right.
But like I said, just patients who refuse or.
I'm going to work our way to you.
Yeah, I agree, and I think this challenging is setting the distinction of what is a non-surgical candidate is challenging, and you see it kind of thing.
Now looking at our ASHR guidelines, and there doesn't say over Mohs, but again, it brings up this cosmesis thing that it just can be additionally recommended if a cosmesis could be compromised function. But it does. I don't think this guideline is pertinent to electronic brachytherapy. Maybe
Okay.
Superficial in electrons, but not.
Okay. So it is pertinent to superficial, though.
I believe so.
Okay. All right. Let's.
Cognetta published a paper earlier this year, trying to come up with appropriate use guidelines of which patients are candidates for superficial radiation therapy versus Mohs. It's certainly not as robust as the Mohs AUC that was developed. It's a small paper with 4 authors that looked at it, but patients who are not surgical candidates, I think we all agree that surgery is the primary modality.
Surgery is primary.
But if the patient is not a surgical candidate, there's 2 reasons. One, because the doctor says the patient's not a surgical candidate because they have thrombocytopenia or some other comorbidity that prevents that. But the other is patient consent. Patients have to consent to these procedures. And oftentimes, if they don't consent and we only give them an option when there's an evidence-based therapy out there that is therapeutic, it ends up in treatment delays. And then these patients disappear for 2 or 3 years and come back with some large tumor. So having options that are evidence-based, the patient has to give consent to it. And I think that's an important thing as we're considering one over the other.
I think in regards to A, you could consider a pragmatic approach and say that, if you're going to choose the non-preferred surgical approach, it should require multidisciplinary consultation, right?
Okay.
That might involve seeing a radiation oncologist as well. For a surgeon, we see an expert radiation physician, and they can collaborate together and make the best plan.
Thank you. Excellent. All right. And again, this question here may already be sort of answered by some of the statements that were made earlier. But how do the long-term cure rates compare with electronic brachytherapy, superficial radiation therapy, and Mohs excision for basal cell and squamous cell, according to the literature? Are there any prospective studies to support EBT and SRT cure rates compared to Mohs excision, since most of the studies are retrospective without longer-term follow-up? So why don't we start on this side?
think you're framed the question the way I think, that there's less long-term data on electronic brachytherapy. And the data is mostly mediocre in quality.
Okay.
Long-term cure rate for Mohs is established at 99% for basal cells and 92 to 99% for squamous cell carcinomas. Back to Cognetta, he's published the most on this. He had a 10-year follow-up paper with 2,000 tumors that showed a 95.2% recurrence rate after SRT.
So
It's not a
recurrence,
95%
not cure.
rate.
Yeah.
I'm saying.
I know it was a slip of the tongue, but I got what you meant. Sir, next to.
Yeah, I mean, there are prospective studies like quality of life and things like that. That the quality of life improves with moves, radiation, skin cancer. There's no head-to-head comparison, but the control rates in the literature for radiation for superficial for the perfectly treated patients is really high, 90%.
I agree, no prospective evidence, but both are multiple large retrospective series showing that they're pretty good.
Yeah, no perspective. I would say the retrospective data for SRT is obviously much longer than the retrospective data for electronic brachytherapy.
The literature shows excellent cure rates.
Agree.
Nothing to add.
All right. Agreed, okay. All right, number 7, and I think it's, pretty evident it's low for both, but if someone wants to address the question, how do the complication rates compare between EBT, SRT, and Mohs excision, both in the short term and long term? Is there long-term data greater than 7 years for follow-up for patients that undergo EBT and SRT dealing with long-term sequelae and cure rates? Why don't we start with this side? And again, if you don't have to answer the question, you can pass on. It may not be appropriate to specific specialties.
I'll pass.
Okay.
Yeah, so no comparative results on that point, but I want to bring up the fact again that the SRT and EBT is going to be on very superficial tumors, and Mohs surgery is going to be selected for more aggressive, deeper ones, and so directly comparing those rates is.
Yeah, because I know, and the reason why I say that too, and the reason why this question came up is because some of the studies that I've seen are trying to compare SRT and EBT to Mohs, and that's not really an apples to apples comparison because we have an LCD and Mohs is selected out. I mean, a lot of times surgical excision for simple small basal cells and squamous cells are preferred and therefore utilized, and so Mohs tends to have a heavy favor towards lesions that are either recurrent or harder to treat, or in H zones, as we talked about, for tibial areas, et cetera, and then including what our LCD recommends from those documentation and things like that. So I agree with that standpoint. I think most people would agree that it's not hard to make comparisons.
Just to reiterate my prior point, retrospective comparisons between two separate patient populations or when looking at events that are very infrequent recurrences for low-risk skin cancers are fraught with massive amounts of bias between the two separate groups, because even a small number of higher risk patients in one patient population versus another has a significant skew to the data.
Because generally the low risk patients are almost all going to be cured. So,
Yeah.
right?
Exactly.
A small handful of
Yeah.
poorly selected patients blows up the whole analysis.
So if we can, and off of that agree, if we can focus maybe on what you may or may not know of long-term complications or sequela related to either treatment.
So unfortunately, I'm going to have to speak anecdotally, and I know that because radiation was used in dermatology offices, 50% of dermatology offices in the 1970s had a Grenz-Ray machine or some other superficial radiation therapy delivery machine. So I have experience looking at long-term cosmetic results and long-term reoperative problems in those patients who had either recurrences, which is only one potential complication, but also cosmesis, loss of hair, skin sclerosis, difficulty of reading pathology in an old radiated field because of changes in the fibroblasts and changes in the fibrosis around remaining adnexal structures, and on and on and on. I don't know that any of that is applicable to modern day SRT. And I don't think modern day SRT has literature established in that long term. Mohs has been around longer. And I don't know that you can bridge back to the older SRT methods. If you can, then there are old papers that talk about long-term SRT issues. But to be fair, there are also issues with keloids and, scars under garments where surgery's been performed and irritation from those. So it's not just one-sided issues. There's two-sided issues.
This new SRT is reported to only penetrate 2 to 3 millimeters. And most of the anecdotal horrible things I've seen are when the bone gets destroyed, the marrow. And so it wouldn't be applicable to this, and it's all data anyway.
I mean, more anecdotal data, but the only real time I would worry with modern radiation techniques are in very young patients. For the reasons we've discussed before, a 30-year-old patient should probably really be pushed to surgery. An 80-year-old patient, less so.
Agree.
Okay. Anybody else want to make any other comments on that one? Number 7, as far as sequela or long-term complications from radiation. Specifically with the superficial radiation, obviously we're talking about that. Okay. All right, so let's move on to question 8. I think this is an important question, and I had trouble seeing this in the literature that I looked at, including in your bibliography. And this may be more appropriate for the dermatologist plastics, but typically patients who are radiated to one area cannot be irradiated again at the same location. Typically, a radiation oncologist would agree with that statement. As a general rule, patients that undergo superficial radiation therapy to one specific area location treatment would not be re-irradiated to that same area.
I would disagree.
Okay.
I would say, Steve, superficial.
That we're
defining radiation as superficial radiation.
I'm defining it as superficial radiation.
I would agree, but patients who are radiated in one area can be radiated.
Yes, I understand, and we're limiting it to superficial radiation therapy, is what I'm talking about here. So that, okay, so we're in agreement with that. So the important part of the question is, how do you ensure, if you're going to offer superficial radiation therapy to a patient that's already been previously treated, let's just say patients that have a lot of actinic damage and have a lot of actinic changes in their face, maybe early squamous cell in situ or basal cells or whatnot. How do you ensure those patients will not be irradiated at those locations, especially since overlapping can occur in patients with a lot of sun damage? So how would you deliver it, or how is it safe to deliver in patients that have had a lot of actinic damage, have already been, I've read some of the articles where it talks about treating 3 or 4 squames or basal cells with superficial radiation therapy or EBT to a particular area of the face. How do you keep from overlapping, and how can you distinguish that so that you avoid potential complications?
So is your question in one setting or over time?
No, so let's just say a patient you cure with a superficial radiation therapy, for a basal cell of the cheek or the nose or wherever you're treating it, and they develop another one close by.
Okay, so it changes, but not
exactly. I'm not talking about here. It's obvious. You can tell that that. But how do you keep from overlapping that treatment if you can't tell, because the results are purported to be superior cosmetically, and you can't tell that they've been radiated? How do you keep from re-irradiating the same area?
Where I think actually radiation being done by a radiation oncologist who has a physics staff present is going to be necessary, because a physicist can, we request this all the time, and there's actually been codes for it, where we ask our physicists to do plan sums of the different areas that were treated, and they can look at overlap in doses. And so then we can make a clinical decision. Is it safe to treat adjacent, not safe to treat adjacent? Are we going to adjust our dosing, our fractionation differently? But that type of process, physicists are the ones that do it. And so a lot of centers that just have these superficial radiation therapy machines without physics support will not be able to do that.
That's the sort of thing.
I would agree that if you're going to treat overlapping sites, then and you're intentionally treating overlapping sites, then yes, some kind of working with a medical physicist to calculate those doses makes sense. We have problems, again, not any specific literature that I'm aware of to this question. The same thing happened with methotrexate dosage before. Methotrexate is a widely used safe drug. But we understand that the risk of hepatic fibrosis is greater over 3 grams. How do we know exactly how much the patient took before? You requested the records from the other doctors and you reviewed it and it made sense. Now with radiation therapy, where you're saying, hey, this person was radiated before on the left cheek and now they have something on their left temple. In my practice over the last 5 years, we have not had a problem getting records from other practices. Fortunately, almost everybody uses EMRs now with photographic evidence. And so you can very clearly identify if the 2 sites are right next to each other on the left cheek, then don't treat.
Well, that's why I'm saying the guideline, this is my the concern that we should have going forward is, they're being treated, and I'm not saying they shouldn't be, but, you're having superficial radiation therapy in a dermatologist's office and they're treating, multiple areas. The patient comes back, oh, I got this all here. How do you know by looking at it? Because you don't know that you're not retreating an area that's already been treated.
Photos.
But they're not that definitive. I mean, sometimes, well, okay, let me rephrase that. With photos, depending on the angle where you take it and how it's taken, you may see a basal cell here and then there's one right here. How do you know that that's not the same basal cell or that you're not going to treat that that's already been treated?
Totally agree. You do not want to retreat the same area, but I think that the chances that shows up, if you can't be certain that the area wasn't treated, then you shouldn't do it. But if somebody comes in and we take so many photos in dermatology, I think if it's within 2 centimeters of the previous site, then no, there's no way you do it. But I think it's more clear based on the day-to-day practice of dermatology. We're so meticulous based on biopsies, right? We get biopsies, the most surgeons in the room get biopsies from clinics that say left face, and with.
But is that to say, you're an expert, is that to say that every dermatologist could have that capacity to be able to differentiate and tell what's been treated and not treated? We're talking about having guidelines to help.
They should have an obligation to confirm.
I would just add the caveat is that we see records from people who have been to their dermatologist. And they go now with a new lesion. They had radiation somewhere else. They don't even remember who the dermatologist was or where. That was on my cheek, and I don't know. And so it's not nearly as clearly defined as someone who has good documentation, like it sounds like you do.
But that makes complete sense. I agree with that. It seems that it would be reasonable to make it incumbent upon the treating clinician to verify that it's safe. If you could put the onus on the physician there, and that's risky. That would hurt a patient.
So there should be some guideline. I guess my question is, if you look, the ultimate question is, should there be guidelines defined in the LCD as to if you're delivering superficial radiation therapy, let's say in a dermatologist's office, when and how you can radiate in areas that are contiguous or nearby or whatever the case may be. And I see it shaking of the head, so I want to make some comments. Go ahead.
Yeah, I as somebody who has done Mohs surgery for over 30 years, I will just say, and has done a lot of legal consulting for the Board of Medicine in Oregon, medical records are crap. There are occasionally very good records, but in my own office, in my staff, I did Mohs on a face. There's a picture of a leg in my records, right? Or there's supposed to be a pre-op photo, an intra-op photo, reconstructive photo, a 1-week photo, da-da-da. Sometimes those photos are there and sometimes they're not, depending on the lighting. I used to teach a course, the American Academy of Dermatology, lying with photography, depending on how you angle the camera and you light and everything else. And so I did have one, I think this is pertinent to this discussion. I did have one referring physician who used very fixed landmarks and measured to millimeters and then drew on the patient and allowed me to really create kind of a map. That was the unicorn referring doc with that. So without tattoos or without some standardization of exact marking and documentation when it comes to field documentation and field overlap issues, I don't think it can be done. I mean, practically, I don't think it's going to happen.
I'll just throw in the extra electronic brachytherapy world. You mentioned that we sort of have safety officers, physicists, right? You're looking over our shoulder all the time. So I promise a radiation chart has a lot of detail, like you're describing, because there's someone else whose job it is to make sure that it's there.
I think that the point is that do there need to be guidelines clarifying what these demarcations should be with recurrence? And if there is a recurrence and it's in an adjacent area, does it need to be defined more thoroughly, whether by a physicist, by a radiation oncologist, to prevent causing harm to the patients.
I think it could be metachronous tumors, right? It doesn't necessarily have to be a recurrence, although that's one issue. It could be a new tumor in that site or an adjacent site.
So I think non-hemorrhageous tumors are probably a more common issue in the setting rather than.
Yeah.
Okay,
Exactly.
so, but my point is that what we're trying to do is establish a safety protocol and safety net for the patients, the beneficiaries, and also for the treating providers to make sure that inadvertently there is no harm
I
done
mean,
because of recurrent therapies that would be.
I know this is a later question, but I would say that generally radiation oncologists train for 4 years in residency to deliver radiation and have staffs of medical physicists and dosimetrists and an entire working armada of people to ensure safety, because radiation is unique in medicine in that you may deliver something that is not harmful in the immediate setting, but can be very harmful in the long-term setting. I mean, I would generally say that much in the way that a surgeon should perform surgery, a radiation oncologist should perform radiation.
And it might be useful, and I'm probably stepping out of line a little bit, but having looked at radiation dots, charts, the documentation is way over my head, first of all, but is very intense. And there may be something that could be drawn from Astro's requirements for documentation of site dosimetry, fall off, and all those other things I don't understand for adequate documentation.
There's both Astro and the American ARS also has communication guidelines for radiation records.
And I'm glad you mentioned, we will be getting on to that, to those specific things. If we get a couple more questions.
The other thing just to echo is like, I just repeat the same point, that radiation therapy delivered in a dermatologist's office often does not have dosimetry and physicists available to them. And so I think that's why if it's delivered in a radiation oncologist's office with the appropriate staff for safety and quality assurance, those overlaps can be assessed accurately.
Thank you. All right, so let's go on, and let me bundle these two questions together because they're really kind of similar, and this is more directed towards the dermatologist who's going to be probably the first person that has seen the patients after their treatments, whether it's from radiation or whether it's from surgery, although obviously radiation oncologists will see their patients as well. So, so 9 and 10. So 9, is it harder to perform surgery on patients who have been previously radiated in terms of cure rates, complications, and cosmesis? And then also, is it harder to detect recurrence in those patients who've undergone superficial radiation therapy and electronic brachytherapy? So let's start with Dr. Baker. So if you can answer kind of 9 and 10 collectively and why, or
Head and neck surgery, facial plastic surgery, unequivocally, yes.
and why would that be?
Very difficult clinically. Now, if it's a surface lesion, not necessarily, but you've got postoperative edema, you've got swelling, you've got scarring, you've got thickness, woody fibrosis, and is that a tumor? Is it not a tumor? You send them down to get scanned, and they might see something that kind of looks questionable, and we recommend clinical correlation, and then you're faced with trying to biopsy it, decide one way or the other. It can be quite even many, many years out, be difficult, especially if it's on a deep margin. It goes up and over top of the parotid.
So I'd like to break the question actually and take them separately. So is surgery more difficult in those areas? Yes, for all the reasons that were just mentioned. You have decreased blood flow, for example, due to fibrosis, and so that makes the healing of any surgical intervention more challenging. There are histopathologic changes that make interpretation of the pathology more challenging in multiple ways. Now, can those changes, are those issues also true in a surgical scar that's not radiotherapy? Some of them, yes, some of them, no. But for a broad field, that doesn't happen in surgery, but it does happen with radiation therapy. And then in terms of seeing the recurrence, one of the things that dermatologists use now frequently is dermoscopy, which is the evaluation of vascular structures within bumps on the skin to determine malignancy, non-malignancy, need for biopsy, that type of thing. And with the late stage radiation therapy vascular changes, that makes interpretation of that now commonly employed modality more challenging.
Yes and yes.
All right.
I guess a little different than the dermatologist's answer. I feel that after patients have healed from radiation.
Yes, that's what I'm talking about with this.
Yeah, typically, yes, the skin obviously can be more firm and potentially could have some fibrosis. But in general, like we counsel our patients and talk to our patients that if they notice any new lesions, raised areas, itchiness, pain, ulcerations, those are all things that we're concerned about as recurrences, which aren't typical sequelae of long-term radiation therapy.
Yeah, I mean, I agree with nine, surgeries. I'm not a surgeon, but I know that.
Sure.
With detection with recurrences, I don't know if I agree with that after superficial radiotherapy, I don't have experience with electronic, I've done superficial with low voltage. I don't know if I agree with that, it's hard to detect recurrences. You know, radiation oncologists are oncologists, right?
Sure.
So we follow patients very closely, often alternating with our ENT colleagues or dermatology colleagues. I'm seeing every 3 months for the first 2 years. And so physical exam, I think is, I don't think that there's a harder to detect recurrences after superficial.
I agree with the sentiment echoed on the other side there. I think the scar is harder to follow up on, whether you're talking about reconstruction or tumor detection.
Okay.
And scar can be created by surgery, particular more invasive, more advanced reconstructive techniques, flaps, grafts. The scar from that is going to be different than a primary closure. And so whether that scar has been created by radiation or by surgery, I think there's challenges with both. I don't think it's specific to radiation.
Anything else you want to add?
I'll just go yes with 9 and unsure.
Okay.
One more.
Go ahead. Yes.
Recurrence in areas of fibrosis is very difficult, given that a lot of times in these areas you have morpheaform or infiltrative skin cancer, and a slight increase in induration in a area of fibrosis is very difficult over time to detect.
Do you know if there's any studies out there that specifically looked at things like that, doing a Mohs procedure or surgical excision after superficial radiation? I didn't see anything after superficial radiation therapy or electronic brachytherapy.
But I think it would be a uniform consensus among oncologists that surgery is harder after any type of radiation.
Okay.
You know, I think that detecting recurrence, no more question.
Yeah, the next radiation oncologist said yes.
Yeah. Okay. So the surgical perspective, yes, and the other one not really defined 100%.
And I'm sure, you know, I would say there's probably, if you had a large enough study, you would probably find that it's somewhat minutely harder to detect a recurrence in a previously radiated field because there are changes, but the scar also makes it challenging sometimes.
Okay. All right, so now I'd like to spend a little bit of time. We're going to start changing it up a little bit so that we can go over more specifics in the use of additional modalities with superficial radiation therapy as well. So, and we'll start on this side. So question 11, are there any randomized clinical trials or comparative studies that show that the addition of image guidance, including ultrasound, improves the outcomes in patients undergoing electronic brachytherapy or superficial radiation therapy, which is what we're talking about?
Randomizing.
Yes.
No comparative. There's no good, high quality data that's not funded by the companies that I'm aware of.
Okay.
And no randomized data that I'm aware of. I'm aware of retrospective studies that compare SRT versus IGSRT to show better improved outcomes. I believe there's a study underway that hasn't published yet at Cleveland Clinic looking at that.
And with those studies, because I've seen some of those retrospective studies as well, and most of which have input from the company or at least association with the company that's providing the device. So I haven't seen anything long-term. In other words, in those retrospectives, they're short-term studies, short-term outcomes as well.
2 years.
2 years, and most basal cells, or a lot of basal cells, I don't say most basal, a lot of basal cells recur after a long period, 2 years, at least a third.
I'm not aware of any literature showing that basal cell, when the recurrence is after. In my clinical practice, recurrent tumors typically show up within 2 years.
Mhm.
And if there's data otherwise,
5 years. Yeah, I would say that more basal cells will recur after between the 2 and the 5th year.
in the fifth.
Yes.
And I would say almost the longer you follow skin cancer, the more of them recur. I mean, that's in the study that you are mentioning from the Cleveland Clinic. It's in Cogneta's papers from Tallahassee. It's in retrospective series from radiation. I don't know the Mohs data as well, but I have to imagine that it's there as well.
And the other question I have, and this is not actually to pick on anything, but if we're talking about the addition of the ultrasound to the SRT, in a lot of in the comparison studies that are mentioned, they're comparing it to older SRT studies. So it's kind of hard to compare older SRT studies. As you said, it interjects bias and things like that when you're comparing SRT studies that are previous done than to the newer SRT that's being delivered. By how much more is UltraGuide adding to the outcome? Because we're talking about small differences. The cure rates for even the older SRT is somewhere 92 to 95%. And so now you're adding ultrasound and you're saying it's 99%. It's a very small difference in a limited population of patients to, I know it was 1,800 with patients on one study or something like that. But again, you're comparing it to older SRT. So is it really statistically significant to compare a 95%, let's say, cure rate or recurrence rate to 99 or 98.9 or something like that? I think it was 98.2, 1.2% that actually recurred using the ultrasound guidance to actually justify the addition of ultrasound, is what I'm saying.
It'd be hard to compare apples to
Right,
apples.
exactly. That's what, okay.
I agree with what has been said. We can discuss the merits of the literature and our personal anecdotes, but to answer the question, there's no randomized clinical study and there is no high quality comparative studies that have been published that aren't, as Dr. Burry mentioned, touched by the company.
Yes, and I add to that just for the record. We, as radiation oncologists with electron beam radiation therapy, right, could also have been doing ultrasound on our linear accelerators or cone beam CT or KV imaging for decades, or at least over a decade. We don't. And the reason is because there is no literature to support it that we felt makes any difference. Vendors have created pro formas when they offer these machines, and they build in this ultrasound code into the pro formas to cover the cost of the machines. We pursued an NCCN edit with CMS requesting that image guidance not be associated, not be allowed, so it's 0, with superficial radiation therapy, 77401, for all 3 IGRT codes. And that's something we've been, and our guidance is also from our society says the same thing, because we don't believe there's any literature very strongly on this point.
And I think this is especially true for daily ultrasound guidance. I could envision a world in which a initial upfront single one-time ultrasound to determine depth of invasion is not wildly unreasonable. And I will occasionally get a CT simulation in my department for these skin lesions just to ensure that there's not deeper invasion. But these tumors do not change dramatically from day to day. So I do not see how daily image guidance, for the same reasons I don't do it when I'm treating skin cancers with other modalities, would improve patient outcomes in addition to the lack of.
If anything, I would think it would actually complicate things further, because you can get edema and inflammation during the treatment of the course of radiation therapy, which you would see on an ultrasound. And so if all of a sudden if somebody's thinking they're going to change their dose, and that now you're changing your dose based on things that aren't related to the cancer, actually.
You all want to add anything?
Yeah, I think the specifics of the literature that we're talking about, the IGSRT versus the old SRT, is important to understand the apples to oranges comparison here. So the classic SRT as far as I read it, was 5 fractions for a total of 3,500 centigrades. And they were comparing that directly to 20 fractions with the IGSRT at over 5,000 centigrades. This is not comparable in any way, shape, or form. And so putting that forward as evidence of the utility of IG is.
Anybody want anything else?
We have lead time bias, right? That the people who are followed longer are more likely to fail skin cancer.
Sure.
So then it increases the chances. I guess the last thing I would add is we actually are using image guidance to our eyes.
Yeah.
You can see the target, right? You don't need an ultrasound to see the target on the skin.
Gotcha. Okay. All right, anybody, good, anything else to that? Okay. All right, so now the next question, and why don't we take this as a whole question, so I'll kind of read through it. This is really gonna be more pertinent, well, actually, it'll be pertinent to both. Because a lot of SRT is delivered at the dermatologist's offices. So the question is, and this again is important for us because it helps us to determine guidance in development of the LCD or local coverage determination. So who is qualified to oversee the SRT or the EBT services delivered to the patient? Can a dermatologist deliver SRT or BT to the patient without oversight or involvement by a radiation oncologist? And then subsequent that, if you can try to address these as well, can the fractionated treatments be delivered by other than a radiation technologist, such as a trained medical assistant or other ancillary personnel delegated by the supervising physician, consistent with CMS guidelines for incident to care? Does the provider have to be present during each treatment session? And they say the provider being either dermatologist, radiation oncologist, or both. And does the patient require an assessment at each fractionated treatment? How are the fractionated treatments determined? Who makes that determination? How is the response assessed immediately prior to, during, and after each treatment session? And what if complications develop during or between treatment sessions? Will a break in treatment alter treatment planning and potentially affect the outcome of the treatment? So if we, and you can take it apart, so I'm going to start kind of going this way. And if you can help us to answer those questions, because I think these are important questions in our guidance.
I'll start at the bottom. Seems the easiest. Yeah, so if complications develop, it can indeed affect the treatment plan. It should affect the treatment plan, and it could affect the outcome. So there's definitely the need to adjust if there's significant complications during the course of care. So how this response to your assessment prior or after each treatment. As we already said, that this is a slow-moving process. The basal cells the need to assess daily is not there from my perspective. As a radiation oncologist, we assess all patients weekly at minimum, both on the table and in the room, to make sure it's the right thing. How is fractionation?
Take a look, and I don't mean to interrupt you, and I have to answer it as well. Are there specific guidelines that we need to know about as to how often they should be assessed? In other words, do you all have guidelines, either in your literature or in Astro guidelines or dermatology guidelines, or guidelines that we need to include in our LCD so that, for documentation purposes, is how often patients should be assessed during that treatment?
Yeah. Assume it's weekly, is that what that? Yeah, so that,
certainly
in radiation oncology, every patient's seen every week.
All right.
Really, every 5 fractions.
Yeah.
Okay, that's what I'm looking at. Remember, we're trying to use the LCD purposes. You all are experts, and that's why we're taking your advice. But we need that guidance in developing the LCD so that all the other practitioners kind of can follow that guidance.
Probably practically, they're being seen weekly if you're doing every other day fractionation or something like that. But our guidelines, I believe, most frequently state every 5 fractions, and much of that's based on billing.
Yeah, I guess in broad category, I'll let someone else go next, would be as far as the medical assistant or whoever else might be involved in giving radiation, who's not a radiation oncologist. And to be a radiation therapist requires 2 years of training outside of high school, right? So compared to us who, had college medical school residency, so that's, I guess, 13 years for us. So it's a very large difference in training between a radiation oncologist and a radiation therapist. It sounds very similar, but it's a very different skill set.
So answer that question, others can answer this question too. And that second one, incident 2, it would not be appropriate, or would it be appropriate to delegate it to a medical assistant to deliver that treatment, or someone else in the office, a physician assistant or somebody else?
Well, to deliver the treatment, they're specially trained and licensed to deliver radiation. The question is to prescribe radiation.
Okay.
At least if I'm understanding the question.
It's actually, yes, you are understanding correctly.
Yeah, so I don't believe anyone should. I personally don't believe some kind of radiation oncologist should not prescribe.
I think you're also asking if someone other than a radiation therapist should deliver the radiation.
Yes, that's yes.
Sorry, the
Radiation therapists have, as Dr. Berry mentioned, 2 years of training and often many years of on-the-job training.
Okay,
Yeah, we shouldn't have just someone who's never had radiation.
Well, that's what I'm saying. I mean, what we're asking is that, because Medicare does allow, in general, Medicare guidelines allows an incident to service, and we want to make sure, I make sure that we understand in development LCD, it's not appropriate to delegate, or is it appropriate to delegate it to a medical assistant? Okay, and the consensus is, and the guidelines are that it wouldn't be appropriate to be delegated to a medical assistant or a non-trained individual.
They're talking to me, I didn't understand the question.
Well, I know, but they seem simple.
No, well, I appreciate
So
the
we need to
clarification.
make sure that we're,
Absolutely not.
that
I
we
mean,
have that.
I could jump in with the thing that, yeah, no, I think there should be oversight and involvement of the radiation oncologist. It's, the radiation technologist should be the one, delivering it, technologist, therapist, not incident to anybody who's taking a course for a few hours or a week. The radiation oncologist should be the one that determines the fractionation schedule. They're trained they've studied this, they know how to fractionate treatments, how to explain it in an LCD, I think is too broad, beyond just saying that it has to be under the oversight of radiation oncologist to determine that fractionation. And yes, the response is assessed every 5 fractions. So.
Would you include, when you say radiation oncologist oversight, would you include, and you can answer this question as well, a dermatologist being the one to oversight the treatment and the treatment planning?
So no, that's what I'm saying. So to the first question,
Yes.
can dermatologist deliver SRT or EBT to the patient without oversight or
Yes.
involvement of a radiation oncologist? I say no.
Okay.
Now, when you say oversight, what does that mean?
Yeah.
A radiation oncologist should be present in their practice, and they should be the ones coordinating the treatment with the dermatologist if it's being done by the dermatologist. So it should be oversight by a radiation oncologist in terms of.
So like a multimodality approach, not necessarily a radiation oncologist has to be on site when the radiation is being given.
The radiation oncologist should be the one who's prescribing the treatment.
Right.
And so it's under their prescription.
But does the radiation oncology perform direct supervision, which means they need to be physically present in the building when the radiation is delivered? They don't have to be in the room, but they have to be. So should a radiation oncologist be directly present in the building when that radiation?
And this may differ from everybody. My personal opinion is yes.
Okay, because
So they
there's
shouldn't
now
just be a
new
consultant.
rulings that it should be either physically present or immediately available via virtual.
Under direct supervision. Or in the hospital setting under general supervision.
Right.
And you mentioned something. Go ahead and say what you just said.
I
Not
asked
as a
not
consultant.
as a consultant.
Correct.
Okay, so now let's go ahead and, because you wanted to say something.
Sure, I would just say that's I think, a fair game for discussion, opinion based, but to Dr. Collins's point earlier, there's literature of radiation being prescribed by dermatologists for 100 years. So in the interest of an evidence-based, literature-based discussion, I would argue that that is a break from tradition. Standard superficial radiation therapy has been done safely by dermatologists in the outpatient setting without a radiation oncologist directly supervising for 100 years. So that would be a change in standard of care based on a literature discussion. So
Okay.
that was part one.
So the other parts of them go along with that. My question is, should a dermatologist be permitted, let's just say to you've determined the quantity, fractionation schemes, everything else for the patient for treatment in their office without advisement of a radiation oncologist?
I think that multidisciplinary teams and advisement through a tumor board is important for the delivery of care, but I don't think that that's been the standard historically, that radiation oncologists have been signed off on every prescription historically in the US health system.
Okay, are there guidelines? I guess my question is, are there guidelines or some sort of literature or something that supports, and there may be, and it may be acceptable, and I'm not making a judgment one way or the other, but my question is, if a dermatologist sees a patient and they're going to have image-guided SRT or just SRT, whatever the case may be, should the dermatologist be permitted by reasonable training, education, experience, and state allowances? Let's just say states have particular requirements. States may have requirements in certain states of who can and who cannot deliver radiation therapy. Should they be permitted, or is it allowable, or okay, for a dermatologist to prescribe the radiation therapy, obviously deliver the radiation therapy or deliver it, using radiation therapists, supervised radiation therapists? That's the question.
Oh, absolutely, in conjunction with, as you said, state regulatory radiation boards. That should, yeah.
Could you review the part of the historical use of radiation in dermatology office? Is this just from years ago? I mean, because I look back in the ENT literature, and there was a lot of people that were radiating kids' tonsils and adenoids in the 50s, but none of us would ever say. Historically, we, the ENT, have been giving radiation for 100 years, and we should still do it.
As far as citing specific papers, I'd be happy to follow up with that.
Or is this more of a, because I have the impression this is more of a new technique. You haven't been giving radiation continuously for 50 years.
I agree that historically radiation was used for tinea capitis, for fungal infections by dermatologists, and that has faded away as time went on. Skin cancers were treated with superficial radiation historically and have been, not maybe as widely. Certainly Mohs in the 70s took over as the primary modality, but it has been utilized by dermatology offices. I don't have specific data to figure out exactly how many treatments were done per year during that time. And I know that my understanding is that radiation is being used, SRT is being used more frequently in the last 15 years.
Are there any portion of dermatology training as defined by the ACGME that requires competency in radiation techniques?
No.
Or part of the board examination process?
No.
So should someone for whom they're training, is there any Mohs fellowship? I don't know who governs those.
No, not formally.
Nope.
Then I think if you have no formalized education requirement during your residency training, you shouldn't be doing something. Like
In defense of the dermatologist, he is correct that they have been doing radiation therapy for skin cancer for 100 years. And I can say this with confidence because I trained, no. 40 years ago, when I was resident, the offices we rotated in were all doing radiation therapy as Trimas, and they treated their noses and everything with radiation therapy, and they made lead shields and used aluminum and did all kinds of things. And that has persisted. Now they've got a new generation of machines that are more accurate, perhaps. We're talking about superficial radiation, 2 to 3 millimeters thick, right? We're not talking about orthovoltage. We're not talking about less than 100 kilovolts or whatever. And dermatologists have been doing it for a long, long time. Now, it is not an official ACGME requirement that they have proficiency in radiation, but there are postgraduate courses that most of these people that are involved in this 3-day courses take, and they that are rigorous, and they cover all aspects of superficial radiation therapy. I don't personally perform this, so I don't know. I'm assuming that the dermatologist pushes the button and adjusts the cone and does all this. I don't know if he has his medical assistant do it or not. I'm aware of one guy who got put in the pokey for billing for while he was in Europe. You remember him? Yeah, but I claim no knowledge of him personally. But dermatology, this is part of our specialty, and there are a lot of people who persist in this, and they claim good results and a lot of good literature to back them up. So I don't think we should, get in, right into the turf warrior and try to kill one another.
Yeah. Well, the other thing is I guess the intention is if there's radiation oncology available to a patient, right? I just don't see a need for somebody who's done 3-day course or something to be delivering this treatment when you have experts who've studied it. Now, if you're talking about something in a rural setting where there's no radiation oncologist available, that's another scenario, whether maybe there could be some exemptions. But I think as a routine basis, we study radiation biology and all this stuff, and we've been board certified in all this. I don't think a 3-day course
I also think another challenge is well, I don't disagree that dermatologists have been using superficial radiation for a long time for many indications, both oncologic and non-oncologic. There is a value in having a radiation oncologist evolve to evaluate if there are other non-superficial radiation techniques that may be more palatable and better efficacious for treating these specific types of tumors that may not be covered by these 3-day courses. Are these 3-day courses also, is there any certifying body for them, or could I just pop up shop next door and say I'm doing the E-Reiki course next week at the residence inn?
They have their own organization. The name of it escaped.
I think it's dark or something.
Okay.
Yeah. But I would remind you guys that if you go back to the original Medicare Act, any physician can bill for any code.
Correct.
And there's no restrictions. And you guys are starting to like kind of shuffle over that line.
But let's not go any further on this. I will say this though, or I will ask this, and I'll start with Dr. Coakley. So should there be some guidelines in the LCD as to what type of demonstration of proficiency or background or training should be required for someone to deliver ultrasound guided SRT or SRT? Because now we're talking about when you add ultrasound to it, that's not typically part of most dermatologist training. I mean, most dermatologists, and just to be frank, typically don't really know how to use ultrasound. It's not something that's typically part of their training in general, yes.
So there's a slight exception to that, just to be
Okay.
clear. I received no radiation therapy training in my residency. I wrote board exams for the American Board of Dermatology. There was no board exam questions as of 1994 on the subject, just to put that out there. I did receive training in Doppler and duplex Doppler ultrasound in my residency, and I know duplex Doppler is a little different than imaging Doppler, or I'm sorry, imaging ultrasound in my fellowship for vascular evaluation for FLAP. So very limited, not what we're talking about here, but it's not completely none.
Yeah, so I guess my question is, and that's fine. My question is, for someone to be able to use all, and again, I don't want to pick specialties, or I'm not trying to do anything like that. Should there be something considered in our LCD to establish what type of training in either image guidance and or SRT should be required, so that not everybody, as someone said, mentioned, any, regular dermatologists had no training, or general practitioner, whatever the case may be, just start using the technology to treat patients. Should there be something, and if so, what type of education should be, provided?
Yeah, so yes, the answer, you
Okay.
should have some training in it.
All
I
right.
think the hard part is figuring out.
And we're talking about both. If you're going to use image as an adjunct to superficial
SRT or SRT.
or SRT, yes.
I think that's a very fair thing. The question is, what do you require? Does it have to be part of the ACGME? I mean, the NCCN guidelines say that if you're going to do Mohs surgery, you should have training in Mohs, but they leave it at that. They don't say
Right.
you have to be a board certified Mohs micrographic surgeon to do Mohs. Many people do great Mohs that aren't board
Yeah,
certified.
and we're not talking about that. I'm talking about what type of general guidelines. And that's, we have, for example, many of our other LCDs, and I'll use one, which y'all are probably not familiar with, but like polysomnography. There's different categories of who can score the test. There's RRTs, CRTs, et cetera, different types of things that are allowable.
Mhm.
Should there be some allowances? In other words, should you have, rather than just company training,
Mhm.
should there be some sort of, allowance by, let's just say I heard of something called DART now, or recently someone said me something about DART. Should we allow training by DART and by other authorities or potential authorities to allow for those types of guidelines, rather than just saying, okay, go to a one-day workshop, from a company or something like that on how to use their particular machine? Should there be some sort of, and as the other doc mentioned, 3-day, intensive training or some sort of training with certification and or testing to demonstrate proficiency in that? And I would think that would need to be included in the LCD so that not everybody is doing it without some sort of education. Would you agree with that statement?
I would agree that training based on, working group probably put it together, but a training based on the principles covered. I think that you run into problems when you gatekeep and you say you need training, you need approval by this single body. because of many of the practices.
Sure, we can multiple
Yeah.
bodies.
It
Yes.
could be multiple bodies.
And we
They have a lot of training around
LCDs.
this.
Yes.
And you can have training from an organization, I'm sure that you guys are, I'm sure have templates for the wording for that, but training by X organization demonstrating proficiency
Right.
in the usage of ultrasound for determining tumor depth in the skin.
All right, I think we've kind of answered that question fully. Let's go ahead and move on for, time's sake, because there are other things I would like to discuss at the end as well. So this is more for, for everybody. And number 13, it's been reported that cosmesis is superior with either SRT or EBT. How does the literature support that assertion to be the case? Is this based upon subjective or objective evidence? Meaning, are you using particular scales? There's visual analog scales, there's particular quality of life scales, there's pictorial scales. So is there any comparison to traditional excisions or Mohs procedures in cosmesis that's supported by the literature?
Yeah, I'll break.
Yes, how about a 5-minute break? And then we'll all right, Melissa, we ready to start back?
Yes, sir.
All right, so I think we left off at question 13 and why don't we combine it with question 14? So in question 13, it's been reported that the cosmesis is, or cosmetic outcome, when we talk about cosmesis, is superior with either superficial radiation therapy or electronic brachytherapy. How does the literature support that assertion to be the case? Is this based upon subjective or objective evidence? Is there any comparison to traditional excision or Mohs procedures in terms of cosmesis supported by the literature? And then to follow up with that, with a proper reconstruction, cosmesis is often excellent and supported by the literature after a traditional excision or Mohs procedure. So would you agree the literature supports those outcomes? Why don't we start with on the left here?
I know I'll start with that. 14, yes.
Yeah.
Excellent literature. At 13, not that I'm aware of, but it's possible I'm ignorant of other.
Okay.
I agree. There's literature, as was mentioned before, it's impossible to randomize a head-to-head study for surgery or no surgery. But there's literature for both Mohs and SRT demonstrating excellent outcomes.
Okay. I'm sorry, so who answered last? Would you agree? Okay, going along, everybody agree? Everybody kind of agree with those statements. Okay. Question 15, for patients who are non-ambulatory or limited in mobility, what is the assumption that recovery is actually easier for them following multiple fractionated treatments versus a single excision and repair? This has been reported by the manufacturers and cited in some of the studies, but how is this measured objectively to be the situation? So if we can start, why don't we start with Jim over here?
Yeah, it's a difficult at best. I think
Okay.
generally it's a surgical, if not a surgical patient, because they're worried of wound healing or whatever else infection, then that will be the. I don't have the answer other than that.
I'm not sure specific literature citing that.
Right,
But
that's what-
objectively, talking about patients with a lower leg keratinocyte carcinoma that's treated with surgery or radiation. With surgery, you will have a wound, right, that you have to care for, and if mobility is limited, your postoperative care of that can be complicated. And with radiation, typically, the majority of cases, you don't have, certainly you can have a wound depending on the response to the tissue, if you have desquamation or not, but people, again, the anecdotal experience, radiation doesn't always create a wound, where surgery by definition does.
I don't think you need literature for them. If you have a patient who has, limited ability to come back and forth for treatments.
Right.
Surgery would be the simplest and fastest thing to do,
Okay.
right? So I guess they're saying that the SRT and EBT would be better for a patient who can't come from multiple treatments. I don't understand why they're saying that.
Are we clarifying the mobility to the clinic or
Yeah.
mobility like care for surgery?
Okay, so you have patients that, for example, that are at homebound, for example, which is fairly common, the Medicare population. So I guess treatment options for them would include SRT or surgical excision. So in those situations, for example, would surgical excision be favored, or would SRT be favored? Because remember, you have to now transport that patient to and from the homebound status. And the reason why that question comes up is because in some of the articles that I've read, they're citing the reason for picking SRT over surgical excision is because it's more convenient for the patient, because they don't have to have a surgery, they don't have to come back and follow for the surgery or something like that. So,
driving.
okay.
Radiation certainly requires more visits on average.
Right, exactly. That's right, especially if they're
That's
homebound.
lame, that's lame.
Yeah. And you.
These patients are like the vein of our existence because it takes so much effort to get them to, and most of the time we'll use hypofractionation and shorter courses of radiation, which probably have a slightly higher risk of healing complications than a more prolonged fractionation course, just so they can actually complete treatment.
So let me get it clear. So, and I know it seems silly, and that's the reason why I'm asking. So if a patient is a homebound patient, for example, and some patients are homebound, and they meet Medicare requirements for homebound, is it better, in other words, if the lesion could be treated equally by a surgical incision or superficial radiation therapy, is one necessarily favored over the other? In other words, if they're homebound, is it more reasonable and necessary for the patient to come in for one surgical treatment, or should they, even if you can hyperfractionate it and deliver less treatments, or is it better, or is it?
I think there's some patients for homebound is a broad categorization. I do think there are some patients where they have terrible leg vascular issues.
Well, Medicare homebound means that they can't leave their home basically without assistance.
So there's no reason for why you can't do that. And I think that it's not a completely one size fits all box, and many local areas do provide transportation for patients to and from radiation. And so, in that setting, it's not like the end of the world to do radiation, especially with a short course of radiation if they have poor wound healing, or many of these patients who are homebound or non-operative for other reasons. But ceteris paribus, a patient who is, has difficulty coming to a radiation facility center, surgery would be my preferred option.
For this example, my understanding for the superficial radiation therapy, correct me if I'm wrong, is that it seems to work best for small lesions. For superficial radiation. For small lesions, the rest of the body, usually surgical excision would work quite well with a single, you close it primarily. So if they had limited mobility, even with poor vascularity, they would probably heal well. So then and if it's that large of a tumor, it's going to have that much trouble. It may not be amenable to superficial radiation, my understanding. In the face, they're going to heal quite well, unless it's an extremely sensitive area, which is a completely different thing. And it would only be one visit as opposed to multiple visits. So for this example, I can almost not see where you would want to primarily almost ever just give superficial radiation.
I agree.
You are given real radiation, which is a different thing.
Is it? For the homebound patient with a 7mm basal cell, I would not treat them at all. I would just watch them.
Yeah.
Right. I mean, and then have the family alert me if it gets bigger or starts bleeding or whatever, and then we would cross that bridge. But they probably shouldn't do
Well, but see, those are important questions to consider, and the point that Dr. Baker is mentioning is important because, there are resources involved, monetarily and also time consumption, et cetera, et cetera. And as I've seen in some of those sightings for the indication for superficial radiation therapy, they're saying for limited patient mobility. And for homebound status. And so I guess my question is, that's not really proven prospectively. I mean, I understand patient choice and indications could vary, and there's some heterogeneity, but I don't think that that's an indication by itself to designate for superficial radiation therapy.
I would say it's a good fact that's an indication against superficial radiation.
Okay.
Right? If you have limited mobility in terms of getting to clinic.
That's okay.
Transportation.
That's what I'm. Okay, that's what I'm trying to get at. Do you follow what I'm saying? And that's why I'm saying, because in some of the things that I've read, they're citing that as an example of a rationale for delivering superficial radiation therapy. And I want to make sure with our LCD, we're not missing that should be a guideline or should not be a guideline. Does that make sense? Okay. All right. So I think everybody's going to probably agree on 17, but I'm sorry, on 16, but I want to make sure that this is the case. Do you support a biopsy in all patients undergoing superficial radiation therapy or electronic brachytherapy prior to the treatment? If not, what situations would you justify without a biopsy?
Absolutely every time. Yeah, 100% biopsy.
I guess the only thing I'd add to that is if somebody's had, multiple areas that have been biopsied and they see the dermatologist and the dermatologist feels they cannot do a biopsy for any reason and still feel strongly that it's a cancer, then obviously we would defer to the dermatologist.
Okay. All right. Well, that's why I asked that question. and again, I wanted to make sure there was or was not a situation, because typically you want a definitive diagnosis for treating, certainly with radiation therapy.
Unless for some reason the biopsy was contraindicated because the person has 4 platelets, in which case they've got bigger problems with their skin cancer, right?
Right. Are there any situations in the literature, number 17, are there any situations in the literature supported by, are there any situations supported by literature where a Mohs excision or traditional excision would not be justified in favor of doing EBT or SRT? In other words, is there a situation where you would absolutely not do a Mohs or surgical excision over treating with radiation therapy? And then that's why I'm asking that question. So why don't we start?
I want to start with the surgeons.
All right, that's fine.
I don't know if there's any literature to support that.
Yeah, that's what I'm asking.
I don't think there's literature either. I think we could all cook up the nightmare patient with 4 platelets and some other things where you don't really want to touch them, and you probably wouldn't deal with the tumor anyways. But if you did, you might favor SRT over certain indications, but that's going to be a super rare case by case thing.
There's the rare cosmesis we talked about,
Sure.
the larger operation.
In the AAB clinical care guidelines from 2017 and 2018 say that radiation should be considered for patients that are not medical candidates or choose not to have refuse surgery. So, and they list SRT as one of the modalities of radiation.
All right, so let's go on to the next question. And this again is more for our purposes, for LCD purposes, and it may be simplistic to you all, but are there any ancillary services, procedures, planning are required with the following: traditional surgical excision, Mohs excision, EBT, SRT? So are there any other ancillary services that that are required, meaning such as pre-screening for, certain things that we should list on the LCD, and there may be none that the patient should be pre-screened for prior to having a treatment with radiation therapy or Mohs or traditional surgical excision.
You mean ancillary service like personnel? Like
Personnel.
If you're delivering radiation, you have a radiation therapist delivering
That's what it
radiation.
is, yes.
You have a physicist oversee that as part of the team.
Agreed.
And dosimetrist.
Yeah, sorry, dosimetrist involved.
Radiation therapist, medical physicist, and dosimetrist would be ancillary staff.
Pathology, you mentioned the biopsy.
Yeah, that's what, exactly. So pathology obviously with a traditional excision, not just excise it and throw it away. I mean, obviously, it seemed obvious, but I just want to make sure that.
Well, we're going to do a biopsy before you do any of these things.
Yeah, right. And you're going to have a pathologist.
That's what I mean. Pathology examine the tissue specimen. Okay.
Include the planning,
I'm sorry. So what?
the operative clearance.
Yeah, is there any other pre-operative? And that's also part of when we talk about ancillary services.
Sometimes you do need to get imaging studies.
Okay.
Patient high risk can't, if it's a high risk or if it finds a physical exam, you may want to get a staging study that's recurrent or just to make sure there's no pathopathy.
And certainly if it's around the eye, they should probably see an ophthalmologist prior. Documented.
It can be considered but not required.
Right.
To do.
That's right.
To do those things.
Yeah, and this is for informational purpose, not necessarily saying everything we're saying here is going to specifically be on the LCD. I just want to make sure that when we go through the process of writing this, that we have all the there's not something we're missing. Does that make sense? Okay.
And I would say, just to back up the staging studies, for patients with NCC at high or very high risk disease, the risk of local regional recurrence within 2 to 3 years, I can't remember the exact, that is probably in the range of 10% or so. So I think that it is reasonable to allow a, staging imaging in patients with NCC and high risk or above disease, but not require it.
On the other side of the coin, I think it should be required to have safety staff.
Yeah, safety staff should be required.
That's the other thing. That was another part of the ancillary thing is that, and we're going to get a little bit into that question, but and I'm glad you brought that up. In some areas you require shielding and things like that. There are state requirements. And so typically the way CMS is, we defer to things like that, like state requirements for, room size. That's a bad example, but shielding, things like that may be required. Now I know with superficial radiation therapy and electronic brachytherapy, there's less requirements for shielding and things like that. And the machine can be moved from room to room safely. So I guess what other types of things are required for delivering that safely without, compromising staff or patient care or beneficiaries?
I just, in leading up to that question, just as a comment, I don't, to the best of my knowledge, the SRT is being delivered by dermatologists now in 2023. It's not like we're just shooting from the hip and pushing a button and it's not so apt without great thought. I mean, we're physicians with extensive training and respect for patient outcomes. And my understanding of the people that I talk with around the country that perform SRT in their office, all have lead-lined walls, have ID badges. There's a radiation therapist delivering the treatments every single time. There's a weekly multidisciplinary tumor board with medical physics involved, radiation oncologists involved, other dermatologists involved. So I think that I just want to clarify that the concept that somehow if dermatologists are delivering SRT, it's one guy with a button between surgeries, I don't think that's an accurate representation.
And I understand what you're saying, your experience and your knowledge, you're an SME on this. But you have to remember there's a broad spectrum, so there has to be some sort of guidelines, in other words, for people to be and requirements, and that's what we want to, in developing the LCD, we have to appeal to not just you as a dermatologist or Dr. B or Dr. C who may be an expert, but there's doctors D through X, Y, and Z that, may not have quite as much training or experience, and they need to be able to follow those same guidelines. In other words, the number one thing is to look out for the safety for the patient, reasonable, necessary, and efficacy for the beneficiary. Yeah. So all those things have to be taken into consideration. It's not just, we know the experts, and that's why you all are here, are helping to develop these guidelines, but these guidelines have to be such that, we can't monitor everybody. We're not here to monitor them, but we establish coverage determinations that we expect them to follow, and that's why we're enlisting y'all's help. And I'm not an expert in radiation. I can't sit here and make determination, nor am I a dermatologist. So I can't say specifically, I may be in some related field, but that doesn't mean necessarily that I'm the one to make those decisions. Yes.
The other thing I would say about, with medical physics specifically, these multidisciplinary tumor boards and everything are more just physicians discussing cases prospectively, right? It's not medical physics reviewing plans. For accreditation of any radiation oncology center by 3 different accrediting bodies, medical physicists are supposed to review each radiation plan prior or within a certain amount of time after the patient starts treatment. And there's weekly quality checks, which we call chart rounds, where they're reviewed together within the department. And so that is part of the quality care that I do worry if there's not oversight from medical physics.
And medical physics, again, it's a great point to bring up. Medical physics, at least in the care of our patients, is involved in every single patient treatment. So it's not, I agree with you, that's important to.
There is variation practice, Well, I said, I know in different states, and there are some, I'm not going to use that analogy with the gun, but it kind of feels like they are.
Yeah. Well, and in setting appropriate guidelines and saying, hey, here, we're going to deliver high quality SRT to patients where it's the best option with good long-term outcomes, both cosmetically and curatively. Yeah, I think that'd be helpful to put in to an LCD.
We're all trying to pick ourselves against not the high quality group, but the low quality group who the rep came and sold them a piece of equipment, and they went to a 1-day training course, and they had their nurse start delivering some treatment. Yeah. That's what we're trying to protect. We're not, that is the core concern from my perspective.
Okay.
So I believe in terms of at least some required safety issues, state regulatory agencies have guidelines out. So I believe all 50 states have a requirement for lead, and that there are certain QA requirements set out.
Definitely shielding requirements and how much radiation can be exposed.
All right, well, let's move on to the next question. So this question, again, and I know we're mainly, because the experts are dermatologists, radiation oncologists, plastic surgeons in this area, but Medicare doesn't say specifically what docs or healthcare professionals can do certain things, and it depends on state requirements. And there are some issues we do, but in this question here, think of it as not just a dermatologist. So is it within the scope of care of a dermatologist or other health qualified care professionals, such as a nurse practitioner, physician assistant, general practitioner, all those other areas to perform the radiation dosing, site planning, image guidance, and other services associated with radiation therapy that is typically delegated to a radiation oncologist. This would include any published literature and societal guidelines and not just manufacturer guidelines. So I guess the crux of the question is twofold. One is, I know we have some varying opinions of who should be delivering the actual radiation itself and supervising the radiation. But are there guidelines for other healthcare professionals, such as physician assistants? And I have seen actually in some notes, in some reviews where the physician assistant is actually signing off the note for the radiation therapy that's delivered. And so I guess the question involves not just dermatologists, but involves nurse practitioners, physician assistants, surgeons, whatever other specialists.
Surgeons or doctors too.
Yes, that's. Yeah, I think that, yeah, they obviously. But anyway, are there any other literature to support one way or the other, whether or not, or societal guidance, whether other individuals should be allowed to supervise those treatments? And like I said, I have actually reviewed records where physician assistants have actually signed off and been the one to deliver the radiation therapy. So I guess my question is physician assistants, other.
Radiation oncology, that's not allowed.
Yeah, there's no literature because it's not possible.
Yeah.
to do
So you
that.
guys don't have nurse practitioners.
We have nurse practitioners that do other things, see consults, see follow-ups, whatever, but delivery of radiation in a radiation oncology clinic is overseen by the or DO.
Yeah, they can only do E&M visits, our nurse practitioners, they're not allowed to.
All right, so let's talk about from a dermatologist perspective. Should a dermatologist be overseeing the delivery of the radiation in a image-guided SRT or SRT, or can it be delegated to a physician assistant or a nurse practitioner?
I've never delegated it, and I'm not aware of any literature one way or the other. Under the input of others in dermatology, I don't know historically if it's ever been used by other groups. I mean, I think it's reasonable to have a physician in charge of that, yeah.
But I mean, I guess in the development of the LCD, should it be allowed the terminology other healthcare qualified professional?
No. Especially, I would say,
And I know your opinion, but is there something?
there's no evidence to support that. I would say anecdotally, I think it's honestly more important from an SRT standpoint, because if you're not, you're either doing this, someone's visually either via ultrasound or direct visualization, looking at what you're treating every day and, ensuring that. And I think that's,
And I trained with superficial,
Yeah.
multiple in
Yeah.
Florida, you did too.
Yeah.
When we would treat skin cancer, the physician would go in the room every day.
Yeah.
And visualize that we're treating the right thing.
We don't ask the question, do surgeons actually do the operating?
Yeah.
We don't say, does your PA go in and do the entire operation? We know that's preposterous to imagine, right? So that feels the same to us, right? That
You
we,
have to understand that this is coming from a place where we have had
Right.
cases, charts, where there is no physician present.
Correct.
Where it's being done by a nurse practitioner, by another ancillary staff member. They're the ones giving the radiation therapy. And what we're trying to do is to get the guidelines in the LCD to have the proper terminology. We're certainly not stating that.
right, no, I'm looking.
So this is more of what are the literature guided definitions of who can give, who can administer this treatment, and does the physician need to be present?
I think our pushback as radiation oncologists is that to us, that's like asking the question to the surgeons, what literature supports surgeons doing surgery? There isn't any, because you can't, we have no radiation oncology literature to support that an MD needs to be present, because if even in a radiation oncology practice, if you were doing SRT and you had just a, PA or NP, oversee the entire process, that would be outside of our accrediting guidelines from ACR, APEX.
That's what we.
and-
That's what we're asking about. That's specifically correct.
We
Either
need to-
literature or societal guidelines.
We need to
as-
have guidelines.
Exactly. We can't just make an indiscriminate decision because we think it's right, even though we may know it's right. The decision has to be based on some sort of.
Supported based on APEX and, which is ASTRO, and ACR accreditation guidelines. ACRO.
All right. Now, asking the dermatologist similarly, we're assuming that the dermatologist is the one supervising the SRT treatment, whether it's image-guided SRT or just plain SRT. Is it reasonable, as you do oftentimes in closures for, most, which is totally fine. I mean, I passed, same thing. So, I mean, is it reasonable to assign it, or there are societal guidelines that would allow the physician assistant or the nurse practitioner to oversee the delivery of the radiation therapy.
So I don't believe that, so that, to expand on that question, I don't believe there are guidelines
Okay.
that look at it. And to your point, that it's somewhat difficult to do that. I never used a PA or a nurse practitioner to close my Mohs wound, so I'm.
But you can find a guideline that I'm aware of that either permits or does not permit a physician assistant or nurse practitioner to oversee the delivery of the radiation
I
therapy.
mean, there's that does not permit, like you said. but
Right.
yes,
Correct. Okay,
We
that's what I'm
limit it
saying.
to a board certified or board eligible radiation oncologist.
And along those same lines, and let's talk a little bit about the image guided aspect of it. What about the physician assistant or the nurse practitioner overseeing the ultrasound, which is obviously being used in a lot of the SRT treatments now? Perform the service, because the sonographer or whatever can actually put it on if someone else is actually doing the what we call professional component, the reading of it. So my question is are there any guidelines that allow for the interpretation of the images for ultrasound guidance, for SRT or EBT, to use another healthcare qualified professional?
Similarly, in Astro, for other image guidance in radiation oncology, the treating physician is required to review the image within 24 hours of the fraction. That's both within our accreditation guidelines and I believe within CMS documentation.
Okay, so Astro does have guidelines that does require the professional person, when I say professional, I'm not saying that PAs, nurse practitioners are not, but requires the physician, the physician to actually be the one, whether it's a radiologist or whether it's whoever it is, but a physician to actually do the interpretation of the ultrasound guidance.
There's a professional component and a technical component, right? And the
Yes.
professional component is supervised by the physician.
Okay.
Does it have to be the supervising
Right.
physician?
It could be a physician, like we say it has to be board certified radiation oncologist. It doesn't have to be the supervising physician. It has to be a physician on that tax ID, right? And so sometimes a center may assign a physician of the day who's going to review all the image guidance of that given day. But it's in our society's guidelines, it's always a radiation oncologist.
All right, thank you. That's very helpful. So on the last question, then I will open it up to some discussion. I do have some other points that I've taken down that I'd like to discuss a little bit further. So in this last question, I really like to limit it to, and this probably be more appropriate for the dermatologist that treats superficial or the radiation oncologist. Should there be limitations on the number of treatments or treatment sessions, use of image guidance, radiation planning procedures, and who can perform these as far as education and training? Now, I know we discussed some of this before, but there's a lot of variation I've noticed in the literature as well as in reviewing patients' records as to how much, gray units are used, how much treatment is used, how many fractions are used. I guess the question is, how is that determined? I've read through the literature, but it's a little bit, as you said, it's like reading an ophthalmologist report. I know we're not discussing ophthalmologists. It's very hard sometimes to read all their numbers and understand everything that goes along there. So from a perspective in developing the LCD and also sometimes reviewing medical documentation, what is it that we need to look for? And are there some guidelines as to, treatment regimens in general for superficial radiation therapy, electronic brachytherapy, and the use of image guidance on top of that?
So I'll start with that. So in terms
And we can go into a little bit of detail of this because
so in terms of image guidance, like I said, we don't believe there should be image guidance associated with it. There also, in terms of simulation, there should not be more than one or two there should be one simulation charge, right? And then a second simulation has to be based on medical necessity. Like the lesions changing in size, some of the patients losing weight, anatomy, that type of stuff, to prevent, because the worry is what's happening is people are billing daily simulation charges and daily image guidance. So those are the two things we definitely want to put some guardrails on to prevent abuse.
And aren't all of the radiation therapy simulation codes, if you look at the practice expense inputs, they have a CT room and some $160,000 simulation things. So I think it's important to discuss in the concept of a simulation, what that entails.
Yeah, so like the practice expense associated with the simulation codes has a CT simulator built into it. And so, which is why like to do daily simulation just by saying you're looking at the patient, and that's not what the description of work was for these codes. So, which is why one-time max, unless there's medical necessity, would be the appropriate.
And that matches radiation oncology practice with electrons, which is functionally day-to-day, very simple.
The vignette I read had the patient suspended in the air with a Foley catheter with dye in the bladder and spinning and running through a CT scan for simulation. I mean that's the vignette I Yeah, I mean, there's a lot more to it.
Yes, yeah, I think the point is it's complicated, right? I mean, you're positioning the patient in a fresh way, you're building a immobilization device, you're reviewing the position, you're then doing a CT scan, and you're then contouring targets and making a plan. There's a lot of work that goes into it as opposed to looking at a skin lesion that is the same as it was yesterday and charging that charge.
I agree with.
Okay.
I would say, just for the other questions, I think the NCCN guidelines are a reasonable starting place for what are allowable fractionation schemes for the treatment of skin cancer. The evidence for fractionation schemes in skin cancer generally is not overwhelmingly strong. And I think that probably if it's within the NCCN, it is reasonable. And there is a page in the NCCN guidelines that lists
Okay,
that.
and that's what we're looking for,
Yeah.
because sometimes we have to evaluate medical records, and we need to be able to see, are they following reasonable guidelines that have been established by radiation oncologists and dermatologists?
And that's in a multidisciplinary setting.
Exactly, so that we know, they're not excessively using it or not doing it enough.
And then from an education standpoint, obviously, we're biased as radiation oncologists. We believe radiation oncologists should be delivering radiation. But I believe at a minimum, there should be some prescribed educational thing. What that is, I don't know. But, if there's no portion of it that's within the ACGME scope for dermatology and training or the post-fellowship training, I think that there should be, radiation can be dangerous, even superficial radiation. So there should be some formalized.
There should also only be one treatment planning charge unless medical necessity requires a replan. So one simulation charge, one treatment planning charge, no image guidance charges for superficial radiation therapy.
And Astro has a guideline, skin cancer guideline. It's published just a skin.
I'm sorry.
Astro has a skin cancer guideline published at that has all this information.
Go ahead.
I mean, I agree, you shouldn't have 100 fractions.
Okay.
There's appropriate guidelines, and I agree that NCCN does list appropriate.
There's like 25 options.
Yeah, it should be an evidence-based, guideline-based schematic with, it's a general guideline.
I think, an option within the NCCN goes up to 30 fractions. I think going beyond that is not indicated in any setting in which you should be using SRT.
If it needed it, you could always refer to a radiation oncologist, or if for some reason required.
That's one other, like re-irradiation or something like that.
You could refer,
Yeah.
that's a complicated case.
Yeah.
That's not something that you would use SRT.
So answering the question, because we talked a little bit about it, I want to get to kind of the heart of some of this as well, so that we know for our LCD. As far as the use of image guidance in conjunction with SRT, should there be limitations on how many image guidance streams used, and when should it not be used?
I think it's a helpful non-invasive adjunct to visualize tumor. The ultrasound use in my practice has helped me certainly at the initial treatment phase to tell patients, no, this is an option for you. Right. If we do ultrasound and the tumor is deeper than 3 millimeters, that's not going to be cured. So we don't do it. It's useful there. Sometimes things that examples of, again, not evidence-based that I'm aware of, or we only do an evidence-based.
Well, I mean, if there's something that's supported or society.
It's a newer technology.
Okay.
I'm not aware, again, there's a study from Cleveland Clinic that should be published soon. Looking at some of the nuances of image guided versus non-image guided SRT in a more high quality manner. For patients with with diabetes, lower leg edema, surgery, you've had multiple prior infections, you're trying to be as non-invasive as you can. And you might select, in my experience, and after discussion with our multidisciplinary tumor group, you might just select 50 kV for your initial treatment. And based on edema of the tumor as you're going through treatment, you want it to be curative, but you don't want to treat with too aggressively and make a wound. So if you notice on the ultrasound that it seems like the tumor, the black space in the ultrasound is getting thicker, then you may increase treatment and change your kilograms. Go to 70 or 100 if you need to. You don't really want to because you're more likely to leave the wound if you do that. So I think it's a useful tool during that. Exactly how many times it should be allowed. I don't have any evidence-based guidelines on the exact number of times, but I think that it's useful to consider that if there's a difference in a change in the patient's.
So if there's some clinical indication.
So if there's some clinical indication, so there is, okay, because one of the questions.
This is informational.
Sure.
When you do your ultrasound, you retain a hard copy of the actual ultrasound image. Pardon me?
A digital copy.
Okay.
What do you do here? I mean, so that's like for follow-up visits. If you're seeing someone 6 weeks later, 8 weeks later, it's nice to be able to compare that. I think it's useful when you're talking about period.
I'm an OBGYN, so we learned how to.
And I agree entirely that ultrasound in the upfront setting seems like a very reasonable and appropriate thing for using superficial radiation to verify the depth of tumor and all that. I think you could probably do it without, but I think it's reasonable. I think the challenge is that these don't change enough and the edema doesn't change enough day to day. If you get one in the middle of treatment because you notice this diabetic patient has now 3+ pitting edema when it was 1+, 2 weeks ago, that seems reasonable to me.
That would fit inside the standard radiation practice.
Yeah.
You evaluate the patient clinically, and
Yeah.
there's a change in condition. You then say, all right, there's a change in condition. I need to ultrasound, consider altering dose or whatever it is.
And that would align with the medical necessity requirements for replanning with external beam radiation.
And that brings up a very important question, and I'll focus this up for everybody else as well. One of the things that we have seen is that with the image guidance ultrasound SRT, is that it's being used for every single treatment. In other words, every single fractionated treatment. And what I've seen in the records, no change, no change, no change. And so why is it necessary to do that? And is it necessary to do that? And then also, should there be a limitation on the number of treatment options you can do for it? In other words, if you're delivering, X amount of fractions per week over 5 weeks or 6 weeks or however the time frame, depending on the modality that you're using, as some of the other members have said, why is it currently being recommended by the manufacturer and also being done on a weekly, daily basis if there's no changes? Why is that? And then it's being billed for that service as well.
I think I agree with you that the clinical input, certainly when there's a change in the patient's clinical appearance, that it's merited. And there's a bunch of ways that things can change clinically. If you're ordering a CBC on somebody every single day and you didn't notice a difference,
Right.
You probably don't need to order a CBC every day. Right? So I think that it would be it would be reasonable in an LCD to come up with some appropriate use guidelines.
And that's what I'm asking. And now that's the crux of what, since there's no literature out there to support using ultrasound on a weekly, daily basis, especially for most of the lesions, which are superficial in nature anyway, less than a centimeter, then why are we using it and how often? I understand we made the point for initial, that was an excellent point, measure the size of the lesion and see if it's amenable to treatment or not. But why is it being used and how many ultrasound treatments are reasonable? And that's what we're trying to find. Since there's no literature to support that, what's a reasonable amount? In other words, what's reasonable? We need some help in that determining those reasonable guidelines, and that's what I'm opening for. That's why I say kind of those questions for the end, and that's what I'm trying to get back to.
Like I said, it's the Astro Society's opinion that there shouldn't be any additional ultrasounds, right? And what we do as radiation oncologists, we do the CT scan and we bill our simulation charge. So if they're using their ultrasound up front to plan it and they bill their ultrasound, that's to create a plan, that makes sense, but, apart from that, there should not be any further need for it.
Unless there's documented change,
Correct.
which we document on our, getting back to an earlier question, we see the patient every 5 fractions. Part of that is evaluating, I treat head and neck patients. Have they lost 20 pounds? Have they, their skin is falling off, has something changed such that we need to change the plan?
But that's not daily image guidance,
Yeah.
right? So I think that, to me, daily image guidance never makes sense.
Yeah.
A repeat simulation, if there's like the example of the edema increases, then you might need a resimulation. But that's a different thing. Like you assess, you say, I need to do another simulation because these things change, you document that, and then you do a repeat simulation, you select different energy because something is different.
So what I'm hearing then, and maybe this is the consensus, and I'm trying to think, if there's clinical changes seen or suspected, that would be an indication to re-ultrasound the patient prior to delivering the fractionated treatment. Because you may have to adjust the kilovolts, and I'm sorry if I'm talking in terms, but, or the number of rads, the fractionation treatment, the gray units, whatever, that you may have to adjust, make that adjustment with the appropriate additional personnel that you talk to, be it tumor board physicists, whatever the other indications are, that would be an appropriate indication for an additional ultrasound treatment, in addition to perhaps the first one to help stage it and determine whether the patient is amenable to actually having superficial radiation therapy. Would that be a good?
I think that sounds reasonable. That's also more in line with doing a resimulation rather than filling for the G code associated with
Okay.
daily image guidance, which from a radiation oncology standpoint is to verify patient setup, which for these cases you can typically do visually.
And it shouldn't be a matter of routine practice, just to say,
Okay.
like, especially if, let's say you're only doing 5 fractions for this SRT, all of a sudden you're saying halfway through, everyone's doing a re-plan, and so they're doing a 2 for a course, that's not appropriate.
That's very helpful. I mean, that's why we're trying to be fair. I mean, we're trying to develop guidelines. We're not picking on one, over another one. That's for the provider in terms. You need something. Oh, okay.
So this is tangentially related, but because I spent so much of my life in the billing world, I've heard some of our radiation oncology colleagues throw around simulation. And perhaps there is a skin simulation code, but when I look at the codes available to build a simulation, what's happening in those simulation codes is not even closely connected to what I think is happening with superficial radiation therapy.
Right.
So that's point one. Point two, when I went through all the ultrasound codes, and there's a list, as you would imagine, many, there's really not a skin ultrasound code either. And so one of the things that they did was 094 the category 3 tracking code for electronic brachytherapy, is they said that certain codes were included, and in other codes, they'll say these codes cannot be billed with this. And I think one of the problems facing this technology is there is in fact physician work and practice expense that is accrued that needs to be compensated for, that is not accurately described by any current codes. The problem is the kind of substitute codes that are like, well, we're going to use this because this is closest, includes over $2 million of CT simulation equipment and the practice expense, for example. So I'm just raising that as one of the concerns as this goes forward, is trying to make sure that appropriate associated codes are identified by actually their resource requirements and physician work, and not just because it says simulation.
Yeah, and 100% to Scott's point that like when we do it as radiation oncologists, we build a recent simulation because we re-CT them. So we're using that practice expense. If we do image guidance, the ultrasound is on our linear accelerator, which is why it's so expensive. The time is patient time on the linear accelerator and in a very expensive room on a very expensive piece of equipment. The ultrasound associated with surface radiation therapy and the simulation, to his point, is not, that practice expense is not there. And so they're substituting codes that have incorrect practice expense and incorrect description of work.
I am not as well versed in.
Okay. Yeah, and we're not going to really get into the coding in this particular thing, and I understand what you're saying. Those are excellent points. What we're trying to determine at this point is just the coverage determination. We obviously will work on the billing and coding that goes along with that as well, and that will all be open for comment and to add this code or take this code out, et cetera, et cetera. What I'm what we're trying to come up with at this point is, reasonable and necessary amounts of, image guides to be used with it. How many, if at all, should be allowed, and when shouldn't it be allowed? Does that make sense? And that's kind of what I'd like to stick to for this, understanding that may be some issues to overcome as well, as far as simulation codes and things like that. So I do have a couple other questions then. So we are fair in agreement as far as, clinical indications for when the ultrasound should be used or image guidance with it. I do have a question though, and I'm having a little bit of trouble when I decipher the literature and also having reviewed records. From what I understand, the ultrasound is used prior to the delivery of the radiation, not concomitant. In other words, where you ultrasound while you're delivering the superficial radiation therapy. Or does that depend? I guess that's my question. In other words, when you do an ultrasound, obviously before you treat the patient to determine the size, if you need ultrasound, if it's clinically indicated, whatever the case may be. But during the delivery of, let's say, a fractionated treatment and you're using ultrasound, are you using it just prior to the treatment? So not concomitant, not ultrasound and treating at the same time, is what I'm saying.
Correct.
Because we do have something in our LCD that talks about when we use image guided therapy, and the one that deals with radiation oncology services, it talks about imaging to maximize accuracy and precision throughout the process, which includes a full delivery, not just during treatment planning. So a lot of times radiation therapy is delivered while the imaging, while you're using the ultrasound device.
So, and I know you didn't want to talk about this, but I'll just bring it up.
Yes.
And let's just make this point. The ultrasound code was built off of a prostate cancer treatment.
Okay.
The image guidance associated with that. That's what he's talking about by this patient hanging. It's a bladder you were looking at. You were looking at the bladder
Sure.
and the rectum and delivering radiation between these two structures.
Okay.
So, and that's why the ultrasound guidance code was created. It was not to look at a 3 millimeter.
Okay.
depth.
So I just want to what I want to make sure of is that I'm understanding it correctly, and we're understanding correctly, we're developing it, that the ultrasound is used prior to the delivery of the treatment of radiation. Okay, that's what I'm making sure of there, and that's what we're talking about as far as number of uses, that are appropriate for that particular patient, if that option is chosen and if it's being clinically indicated. I'm not talking about the initial one where you may need to determine the size and depth of the lesion and whether treatment is indicated or not. So we're almost done, and we'll completely open it up for everything else. But I have a couple questions just because it helps to educate. I want to make sure I understand. I've read in some of the literature talks about the use of the 22 megahertz or ultrasound device that's attached for this. So if anybody can explain that, how is that able to differentiate? I look at some of the images, and you could see, like, for basal cells that were nodular, well saucered, saucered little, you could kind of tell where it ended and see a little area around there. I'm a little bit having difficulty understanding how those images you can use to determine, like sclerosing basal cells or, cancers that are poorly differentiated squamous cells, things like that, because they're not always that well circumscribed. So how is that adding utility, and what specifically is it doing? I mean, I have trouble reading those images. I can imagine, and nothing against dermatology, but I can imagine a dermatologist having difficulty reading those images when it's more appropriate than what I've trained in the past. So I guess that's the question that I have.
Yeah, it's a good question. And I think that there's no one perfect imaging modality.
Okay.
Right? You look visually with our eyes. It was mentioned in dermoscopy earlier that we utilize to assess tumor boundaries. There's a lot of people that are looking at confocal microscopy for mapping borders, certainly with Mohs surgery, preoperatively to assess, make sure that you're completely treating the tumor in its entirety. So ultrasound is one modality to utilize. And I agree with you that there are certain absolutely cases where there's a perfect nodular basal cell and it's a very clear black circle. And there's other times where you're not sure. And I agree that, I think the literature will support that 50% of tumors are heterogeneous. So you might biopsy a superficial basal cell, but there's an infiltrative component underneath it. I think that the sensitivity of ultrasound for infiltrative basal cells is probably less than nodular basal cells. I personally would never treat a poorly differentiated sclerotic squamous cell with radiation in the first place. So I wouldn't utilize it for that.
Okay, and that's very helpful, because that's what I'm trying to understand, and for all of us to understand is when is it indicated, and we talked a little bit about the clinical indications to determine the depth, things like that. But I do find that the literature doesn't really define very well how they're making that differentiation. And the well-saucerated ones, like you said, I mean, I can see, where it starts and stops for the most part. without having taken, a 3-day or whatever amount of education to do that. But other ones, it's just very nebulous a little bit. And I've used, we've all used ultrasound in our various fields, in the past. So, I mean, from that standpoint, that's what it's helpful to us to understand that and why that makes it necessary, especially if it's hard to tell. Anyway.
Sorry, just to drive to the point again, though, there's a difference in the assessment.
Right.
The planning session, what we're calling simulation, and the daily treatment. Like, for me, the daily treatment, it's hard to imagine that basal cell change much from yesterday. Right, so we don't need to evaluate, we don't need to aim the radiation with the ultrasound. That's what we're talking about for the daily imaging. Hitting the right spot. We can see the right spot. Now, I agree, at the planning session, we should use all the tools at our armamentarium to make sure we get the best plan. But the plan doesn't need to change tomorrow, because this is not a fast changing process.
And what about with squamous cell?
Same. I mean,
Same
it's
thing.
not, it's not changing day to day.
Okay.
Right, and if it does, you can clinically see that, and at least in my paradigm, then you say, oh, something's changed, I'm gonna evaluate it as a physician, I'm going to assess it further, I'm going to then replan if necessary. That's never in the space of daily imaging or daily planning.
And like with like I said, the example with the ultrasound code was for prostate cancer, and the bladder and rectum does change day to day. And then you don't replan the patient, which would have been a simulation code. You adjust how you're aiming the radiation based on the ultrasound. That's not what's happening in skin cancer.
Let me have you clarify. You've used the words simulation and planning interchangeably.
No. So simulation is the initial gathering of images to create your plan.
So you're not simulating treatment.
You're simulating setup, and you're simulating immobilization. You're doing a lot of that work. Then those images are transferred to our treatment planning software, and then we do the treatment planning on the computer on those images to create a treatment plan. And then it's delivered. But
It's a different definition of simulation. You're
Yes.
not simulating the treatment. You're
Right, but
simulating.
You're simulating the treatment position. And for like an electron-based external beam for skin cancer, a simulation, you bring the patient in, we may not necessarily get a CT, but we're demarcating where we want to treat. We're creating a lead shield typically, or tertiary collimation in some way at that time that is then used, that we're doing the treatment plan at that time.
Thank you.
Simulation is basically the positioning setup.
Okay.
yeah, but for surface radiation therapy, the simulation that we say is not the same as what they're using for surface radiation therapy with that machine.
Because I think that is a confusing name, and I think it would be confusing for coders, because you're not actually simulating the treatment.
Well, our coders, learn.
But I'm talking about.
I agree, it's a confusing name, I don't use that nomenclature when discussing the.
Yeah, I call it a planning
I
session.
do as well. We
That's
should
why
get-
I.
Yeah.
Maybe we should.
Yeah.
But the charges are called simulation, but they're pretty much planning session.
All right. So I have a little bit of some other additional things that I wrote down that were maybe a little bit confusing to me. And want to make sure it's clear for us when we develop this. So who actually reads the ultrasound? In other words, and what real-time changes are actually made? So when you're doing it, when you're doing it for superficial radiation therapy or electronic brachytherapy, and you're using the ultrasound, and as I said, most of the time what we're seeing is it's actually with every fraction or every treatment in essence. Who actually is reading those ultrasounds in general?
In general, physician, not really, no, physician.
Okay, the physician,
Yeah.
because most of the ones we see, or a lot of the ones we see, are the physician assistant. So that wouldn't be the standard of care. That would not be.
Practices out there.
Right, sure, understanding that, and that's what I'm trying to help with the guidelines, so it, in the opinion, or at least in the supporting literature, it should be the physician, or could it be the physician assistant or nurse practitioner reading the ultrasound and telling them, go ahead and proceed and change the settings?
Ultimately, if the prescription and the guidelines and literature say the prescription comes from the physician, and the reading of the ultrasound is to change the prescription, it should probably be the physician. I don't know guidelines specifically for that, but.
That would align with ASTRO
That would align.
guidelines
Okay.
for daily imaging, for
Okay.
on-treatment imaging during external beam radiation.
Because as we talked about, we can't just blanket, when we do allow for other healthcare professionals, we have to have recommendations or guidelines or literature that supports who should be the one doing the interpretation. Because if we get medical records review, we have to look for things like that, or people have to look for things like that. And so those are things that we need to know and need to be elucidated on the LCD. And that's what we're asking for guidance, even though it may seem, obvious, it's not necessarily always so. That makes sense? Okay. Then I guess the other question, should the ultrasound be documented? In other words, do you think it's okay to just say ultrasound's fine, no changes? Should we expect to see some documentation of the ultrasound images in the medical record?
It is, again, that's hard.
Okay, you have that.
And I surveyed all the SRT practices.
Sure.
It is my practice that we retain all of those digital images.
Okay, when you say retain, it's one thing to retain, like PACS has a system. I don't know if you're familiar with the radiology, that's where they store things offline and whatever. But should it be included?
Note.
In the note, exactly, in the medical documentation.
That's reasonable.
I don't know if it needs to be the actual image.
Well, no, it's the image.
Do you send the image electronically in some way, or how do you authenticate you did the work?
Yeah, by signing off, the electronically certifying.
So not knowing anything about this, it makes me wonder in LCD development if there should be some guidelines that a typical ultrasound image report for this should include depth of penetration, tumor description, volumetric calculations. If you can do that with multi-axis ultrasound, and obviously you can't do a volumetric calculation on semi-amorphous mass, but if you've got half a sphere, you can get close. And I don't know that even that's appropriate or what that would do, but if the carriers wanted to make sure that the ultrasound had some bearing on the treatment course, then probably requiring some documented parameters around what was discerned on the ultrasound makes sense.
See, but my worry is still that if the goal of this LCD is to focus on evidence-based guidelines and data, there's still, in my opinion, there's not been any rationale for why ultrasound should be done for this treatment. And to just have it that the documentation says depth and this and all that, any vendor is going to make sure their ultrasound machine is going to have the capability to create such documentation. And then it'll be submitted in medical records. I don't think just creating without evidence to show why it's clinically necessary, just having documentation surrounding describing tumor is sufficient.
Well, that's why, and that's a good point. That's why we asked for clinical indications of when the ultrasound should be used. And so if it's not indicated, it wouldn't really matter whether it was documented or not documented. Does that make sense? So in other words, if the guidelines per se say you have to have, you do it, if necessary, you do it at the preoperative assessment or the pre-treatment assessment, I'm sorry, preoperative, but the pre-treatment assessment, and then you do if it's clinically indicated, if the provider should charge, try to use it in between or decide to use it in between, but it doesn't meet the medical or clinical indication, it really doesn't matter. Does that make sense from a coverage standpoint? It makes no difference at that point. But if they want to keep doing it, they keep doing it. There's no reimbursement allowed for that in the LCD if they're not meeting the medical indications for usage of the ultrasound.
But the clinical indication can't just be describing the tumor.
No,
or describing the clinical indication. Really, like I said, there's no evidence, to my knowledge, of a clinical indication to do it. And so, I think it would be a one-off thing that you have to do a peer-to-peer, and you'd have to really explain why you're doing it. It's not something that could just be documented because there's no clinical indication for it.
No, other than we don't do peer.
Right. Peer-to-peer. That's not us. But I mean,
Talking about the analogy, we use electrons to do superficial. We don't do any of this, sound guidance. We don't do any of that.
Sure.
Right. So, small tumors, high cure rate. I mean, it's sophisticated to do ultrasound and all that. There's no data for that, that's necessary.
Well, that's the point. If there is no data, and that's what I'm trying to focus on. I don't think there's and there may end up not being. And that's the point is that it's twofold. One is is it reasonable and necessary, or is it an acceptable alternative to deliver superficial radiation therapy for small lesions? If that's the case, then is it also acceptable? What indications would there be to add image guidance on top of it? So if one is correct, if A is correct, then you have to look at B and then say, okay, what indications are there for potentially using B if you've allowed indication A? Does that make sense? So we have to have guidance if SRT superficial radiation therapy is allowable treatment and reasonable and necessary for small skin cancers or indications that are so validated, then there needs to be something for image guidance in conjunction.
No, I agree with you, but I don't believe there's any clinical indication for image guidance for skin cancer. The other thing is, if there needs to be a discharge, it should go through the appropriate CPT RUC process, right? The ultrasound charge was created based on evidence to show that doing an ultrasound daily with prostate cancer, there was clinical data to support that. And that's why the code was valued by CMS. There's no clinical data to support this. So if that's the case, then a category 3 code should be created, it should be investigated, data should be collected, and that's how it should go through this process.
And the other option is to allow it to be bundled. In other words, to have no additional reimbursement for the image guidance usage for SRT. So that may be something that's determined based upon the literature. I can't say that at this point because we have to review the literature and review the determinations and things like that. Go ahead.
I guess my question, I don't understand a lot of this, but in surgery, we get paid one fee. Right? So if we use an ultrasound to find the nerve, or we use something else, it doesn't really matter. So I'm not sure, is it a different thing, even if they would be using the ultrasound to guide the therapy they already had paid for?
Yes.
Yeah, there's
We're not a horse dealership. Every option costs something.
So there's the diagnostic ultrasound.
And this is about during the treatment process.
Yeah.
Yes.
That's what you said about bundled. It's not bundled
Yeah.
now. So currently, you might get paid more for the ultrasound than actually delivering the radiation. If you're billing it in this current way, which I believe is wrong.
One for the treatment, one for the daily ultrasound.
So if, for example, and I'll phrase the question, let's just say you need an ultrasound prior to treatment, which it may or may not be, supported by the literature, but presuming it may be supported by the literature to do an ultrasound, certainly to determine whether a patient sounds reasonable. If a patient is truly a candidate for superficial radiation therapy or electronic brachytherapy, then perhaps, the ultrasound may be indicated and, to determine that's determined, you may determine not, in which case then you still perform the ultrasound service. Or the ultrasound service may be some utility in defining the treatment parameters. Then the question comes in each subsequent fraction, the patient, let's say they undergo 5 weeks of treatment or, for SRT or less for EBT or something like that, then if the ultrasound is not proved or shown by the literature to be reasonable and necessary to be done separately, then the SRT is still needed, the fractionated treatment is still needed, and maybe the ultrasound improves the outcomes, which, I know sometimes, like for example, if you operate with surgical loops, you might improve the outcome, with your suture repair or something like that. So should it be considered, it just as part of the fractionated treatment? In other words, you deliver the treatment, you wanted to use ultrasound to make sure that didn't change. And if it didn't change, then there really shouldn't be, or should there be, a separate billable allowance for the ultrasound? Maybe it should just be part of that. If the surgeon, if it's not a non-radiation oncologist, but it's a dermatologist feeling more comfortable using the ultrasound to make sure their treatment is right on the mark, then ultrasound is really integral to the procedure. You don't get paid, for example, if you're doing a wide local excision with a repair, for example, none of those. But we're talking about a surgeon does a wide local excision and does a 14040 local advancement platform. They don't get paid for that. They don't get paid for the excision as well. So why should the ultrasound be reimbursed separate from the SRT treatment? Do you follow what I'm saying? That's the question.
If they're being used.
If they're being used in conjunction, because you're not a radiation oncologist, and I'm not picking on you, you're a dermatologist, but you just have it facing you. So you're doing the treatment, why should you be paid in addition for the ultrasound treatment in addition to just the radiation therapy?
So 77401 superficial radiation code has no physician time.
Okay.
So there's no physician work with
Sure.
it, so any additional work by a physician wouldn't be.
And I think a challenge is defining what image guidance is typically used for. It is for guidance, not for tumor verification or anything like that. You know, we use image guidance in radiation oncology to ensure that the setup of the patient is accurate, and we use fancy image guidance techniques to allow us to reduce the margins that we put on treatments that are solely generated for inherent uncertainty in daily setup. To my knowledge, I don't know how ultrasound would accomplish that on a day-to-day basis. If there is a clinical indication, if I have a patient where I'm worried that their tumor has changed or something else about them has changed, I can get a separate diagnostic scan or a separate image, do a repeat simulation like we've talked about to replan the patient. But that's not daily image guidance. For skin cancers that we treat without superficial radiation electron, we can do daily image guidance by looking at the tumor and verifying that it's in the light field of the machine.
So I guess what I'm hearing, and this is what I'm trying to understand, is, and we have plenty of other LCDs and various other subjects where a provider may do an additional service, but they're still only paid for that primary service that's covered by the LCD. The other one, whether it's medically necessary or not, and they're doing it, there's not a separate reimbursement for that. Does that make sense?
I agree, the way this code is structured should not be separately reported.
And I think there's certainly no harm to doing a daily ultrasound.
That's like, akin to GYN. A lot of people, when they put an IUD in, check an ultrasound. They don't get to charge for that. They want to just sleep at night. So they check to use an ultrasound to make sure that the IUD is appropriate place. That's called checking your work. You don't get extra money for it, but you sleep at night.
My workflow is that you do the ultrasound of the tumor, but whenever you are actually putting the cone on, it's a visual, put the cone over on the tumor, right? The ultrasound is not built into the cone. Correct. So you're doing the ultrasound and kind of using it to maybe replan like another simulation. But then when you're docking the machine, it's someone visualizing the tumor on the skin, which is what we do in radiation oncology to put the cone on, right? Correct. So the ultrasound is not actually used to help you aim, per se. Radiation. Correct. Okay.
I mean, yeah, I'm only caught up with the wrong thing, but I mean, it's basically unnecessary. It's only done because the companies marketed it to sell their machines. I mean, that's just my opinion, but it's just, it's just the way it is, right? None of us do, ultrasound daily imaging of skin cancer. We were all committing malpractice, or the company was trying to juice the revenue of the model. Right? It's just as simple as that to me. So I don't want to get too complicated about what ought to be included in what. What's wrong shouldn't be paid for, right? And that shouldn't spread into other things.
I would say what's necessary.
Yeah, right.
It's probably.
It's reasonable and necessary. So remember, Social Security Act 1862 A1A, which is pretty much what we base all of our decisions on, is reasonable and necessary. And then there's documentation requirements that follow from the integrity manual. But the issue is, sure, you can do it. Is it really necessary to continue to do it? Does that make sense? And if it's not necessary, doesn't mean you can't do it, because we don't want to prescribe what you can and can't do. If you feel comfortable doing it, some people that operate as surgeons prefer headlights. Some prefer a overhead light. So we don't fault you for doing the tool that you need. Now, it's probably or maybe reasonable, depending on what the literature supports it, if there's changes and you need to add an ultrasound to modify your treatment for some reason, then those may have literature supporting or studies that come out or things, guidelines that say, okay, you've performed an ancillary ultrasound service, not just because it makes you feel better during the treatment, but an ancillary service that should be allowed, for payment, additional payment in those particular circumstances, perhaps. And again, I'm not saying one way or the other. I'm just saying that sounds like it could be reasonable, or an argument could be made for reasonableness. An argument for reasonableness is not there if there's nothing to support the continued use of the device, if it doesn't change or do anything to affect the outcome of the patient. Does that make sense? And that's the inevitable, I think, thing that should be considered in making the determination. I think we would all agree, and we're getting close to being done because I know everybody's going to get antsy. I think that SRT and EB, maybe perhaps EBT, and certainly surgery, there's reasonable options, to treat patients in the right indications, obviously. And that's where we sought your expertise, and we appreciate that in getting us that information, because that helps us. When we do finally put out the LCD draft, you all will be able to comment on it again. So it will be open for public comment. And we're always reachable, me and the other CNDs. If you have, questions and things that we've discussed, you can send it to our, what is it, B-Policy mailbox? B-Policy. Okay, b.policy@palmettogba.com. So you can certainly do that. We're open, for, further discussion before we even finish the draft. The draft's not been made yet at this point. So that's why we're doing this, is so that it's helpful to make the draft. And then it'll be posted, and then there'll be open comment, and you can comment to us, hey, consider this, and the billing and coding article will also be there. So we'll see how that works from that perspective as well. I do have one last question, though, because I'm not quite 100% certain on this, and then if there's any other comments, we can make that. Why is it that SRT, it seems to be, at least in general, is really, you're cell limiting or limiting yourself to, besides guidelines, or there's no investigational work for really trying to treat larger lesions? Why is it really just, from what I have seen, predominantly small lesions? Because if you look at the mean and the few retrospective studies that I've seen by Tran, I think, and you was the other one, I'm trying to remember who they were. They really were, if you looked at the mean of the lesions, that were treated, the lesions, they were less than, it was 1.2 centimeters was the mean. That means that a good half of them, not the median, a good half of them were very small lesions. 5 millimeter, 7 millimeter, 9 millimeter, whatever. I've seen in most of the records we get are 0.6 millimeter, 0.6 centimeters, so really small. And why is there a paucity of not treating ones that are larger lesions? I guess that's my question.
Depth of invasion. The surface techniques do not penetrate deeply into the skin. A larger lesion is more likely to be deeply invasive. Those need to be treated with either surgery or with a radiation technique that can penetrate more deeply, such as electrons or photons.
Okay.
What he said.
All right. Any other comments on that? And it doesn't really, if you're not a radiation therapist, it's hard to decipher and understand that. And that's why I try to understand why the literature I'm reading really is treating predominantly smaller lesions.
The wider it is, the more likely it is.
Yeah. Got it. All right. That's
something that it's rare to find 4 millimeter tumor that's 2 centimeters deep.
Yeah. Okay.
If you've got something that's 8 centimeters across, it might be 8 centimeters.
Okay, that's helpful. That explains the understanding why it seems to be self-limited, at least in what I've read, to smaller lesions, and explains the mean being smaller. All right, so now I'm going to open it up to any other last-minute questions or comments. This is strictly for the FMEs, not for people that are listening virtually. So just want to make that clear.
You guys know what whack-a-mole is? Game. It's like.
I'm sorry, can you say it louder?
You know what whack-a-mole is?
Yes.
So it's a game of amusement park where you hit them all and then another one pops up.
Okay.
So historically, when a particular code is limited by, say, an LCD or payment policy, another creative use of a code set then replaces it. And my suspicion is that addition of the ultrasound probably followed that paradigm. So posing this to my bad onc colleagues here, you guys need to think what other services could replace ultrasound if it is limited.
Yeah, so the worry is, thank you.
So I was, sorry.
Yeah.
I was looking at the EBT, the 0394T, and it is commonly reported with hypothermia, hyperthermia. Yeah, hyperthermia code. And could you put a heating pad on an SRT machine and then do that? So you guys need to think about what other ancillary services could be attached to this in the future that we as a group might want to.
I have to run it.
I think the biggest thing to limit it is also RF, the simulation codes, because we don't want you putting a restriction on image guidance, and then instead the vendor tells, well, there's no restriction on simulation, so we'll start building a daily simulation code. Also inappropriate. So that would be the two things I would be really very cautious of when you write your LCD on, because I personally don't think there's any clinical evidence to support image guidance for skin cancer. nor simulation charges. And so those would be the things I would limit it to. Hyperthermia, I don't know if they'll ever get that creative, but you know.
I have one comment. There's a lot of stuff read in the thing concerning cosmesis. And I know you guys, one of the questions is that, traditionally Medicare doesn't pay for cosmetic procedures. So just because a patient shows up and says, I'd like to have something done, it's equivalent to something else, because the cosmesis is better, I think is something that needs to be thought of. There's a difference between functional cosmesis, i.e. I'm taking out part of somebody's eyelid, versus they may not want a scar on the side of their face. And, I know you guys wrestled out with other things. Just because somebody needs a cataract lens doesn't mean they get the most expensive.
Correct.
Right? And there can be a lot of discussion that says, well, you would do better with a variable lens. But if you want that, you can pay for that. So for a lot of these, especially if they're just dealing with very, very small lesions, it's very acceptable to just excise them, take them off the pathology, close the wound. That can be done under local easily for many of these patients. And many of these same patients who are quoted as to be poor surgical candidates are the same ones that I see going into the OR every day with my ophthalmology colleagues getting their cataracts done. So
Yeah,
we have to be good stewards of our financial resources.
that is an excellent point. So I guess the question, that's an excellent point. So, because we'll need to address that in the LCD as well, is that what facet, because you can advertise, there are plenty of advertisements out there to patients. Oh, this is an alternative, to having surgery. Are you tired of being cut on? Are you tired of having, Mohs procedures? Are you tired of having scars? So, I mean, and that's a hard question to answer too, is so we know that cosmetically, I think it's reasonable superficial radiation therapy is or electronic brachytherapy is going to result in a pretty good cosmetic outcome, at least comparable and maybe in some cases better than Mohs excision or surgical excisions, depending on the location, certainly. So, but as Dr. Baker said, it is analogous to a patient that has cataract surgery, and we know that we cover the traditional monofocal lenses, but we don't cover the multifocal lenses. We don't cover the light-based lenses and things like that. Which I'm paying for soon. But anyway, so my point is, we need to address that to some degree in the LCD. How do we help determine, or please give us some input as to what determinations should the patient allow, be reasonable and necessary for the patient to choose over just because, hey, I've got a basal cell here on my cheek and I really don't want to have a scar there. Can we do radiation therapy? So,
It's a great question, and off the cuff, hearing it, I think the complexity of the reconstruction required personally would go into that. So I assume that most of the people who do surgery here, it's a slam dunk if you're doing a primary closure in front of the ear, right? Most of us would say that that's an excellent cosmetic outcome. Something requiring a skin graft on the nasal ala, I know that and that's an example of where the literature might not reflect reality. I read the literature, and maybe there's far better surgeons sitting across the room from me, where people claim 99% perfect cosmetic outcome for their skin grafts. Sure. I don't know, when I have dinner with my colleagues and in my personal experience, not every skin graft takes. People who use tobacco even wear CPAP. So I think when you're talking about cosmetic outcome, it would have to include the complexity of the reconstruction required. Okay. And if the reconstruction involved with surgical extirpation of the tumor and stitching is going to require flaps and grafts, that's not an apples to apples. I agree. Primary closures, much more reliant about
0.6, 0.6 centimeter lesion, even if it's on the ala.
Yeah,
you can leave that to granulate and heal fantastic. Over time, I've seen many people like that.
Universally, rhinal sinus, sebaceous noses, I think it's a more variable outcome. And there's other people in the room that I don't think that you can, I think saying that you could leave a 6 millimeter hole in the ala, again, due questionable depth if it's, 2 millimeters deep. I think that's.
And I understand the nation, let's talk about, and I understand this from perspective, from the surgeons that, yes, it should be closed primarily, it should be not treated with radiation, but I'm talking about, for example, things, center of fat cheek and aging cheek, I mean, there's plenty of skin there, there's plenty of skin on the neck. Unseen areas, there's plenty of, for small lesions, I mean, the patient says, I don't want a scar. I mean, is that a reasonable reason to offer superficial radiation therapy? I mean, it's a much more
That's a fair question.
expensive modality than just a simple treatment. So
Radiation for a 3 millimeter basal cell on the shoulder.
exactly, that's what I'm saying.
In
There
my
are,
practice, I would not.
okay.
The question is, are you willing to say you're going to force them to have surgery?
No, and I don't think you should ever force that. But but there's got to be some guidelines. They can pay for themselves, and that's where you just have to sign an ABN. That's why we have advanced benefit nurses. Yeah, exactly. It's a very medical necessity need to weigh into the equation. So just to say, because I prefer that because I see advertisements, it looks better, and I'm going to go with that. That's not necessarily an indication. It's the same thing with cataract surgery. It's the same thing with other things. That's why we have Medicare has advanced beneficiary notices. Patients can sign waivers and say, let's say they have a 3 millimeter or 4 millimeter, one on their central chest or cheek or some other area that's easily excised. And they're saying, well, I just don't want it because I don't want a scar or something like that. Or I don't want to, I don't want to have stitches or something like that. And I understand not forcing them, but then there comes the option of an advanced beneficiary notice where they can still have the procedure. It's just they're paying for it instead of CMS is paying for it.
I think a general rule of thumb is, something on the face, that's where, most, I mean, we have, patient wishes and what, cultural differences and societal norms and all that. But many people would say, scars in the face or stuff like that is where the cosmesis comes up, arms, legs, torso. That's not a reason to, I mean, if you're.
Okay, but I understand what I'm saying is in the sensitive areas, the H areas, the areas typically reconstruct, previous surgery, whatever the cases may be. But I'm talking about your typical things like cheek, the forehead, central forehead. I've seen small lesions there, the temple, things like that, that could easily have been excised and closed with one treatment. And I'm reviewing the record and I'm seeing the patient really doesn't have any medical history that would negate doing that. I'm not sure why that was a primary treatment. There's nothing documented in the notes really to say except that the patient preferred that. And so, I mean, there's got to be some sort of limitations or some sort of guidelines to what, or at least give them, a documented reason why they're choosing that alternative. If you want CMS to cover it versus an ABN, advanced beneficiary notice.
If you live out the daily imaging and the daily replanning, it will make the cost not such.
And I think it was said, just to repeat, there's functional cosmesis and then there's appearance cosmesis. And I think where functional cosmesis comes in, the best treatment should be selected to maintain, critical body function. When it's cosmetic cosmesis, which I know is a double statement, then it becomes more in the realm of an ABN.
And again, I'm not picking one treatment over the other. I mean, I certainly think, patients have a choice and decision-making in their process. That's obviously, the standard of care. But again, we have to go by reasonable and necessary and what's, reasonable and necessary and accepted and peer-reviewed, et cetera, in order to make those determinations for the beneficiaries or to, for the providers to help make those determinations for beneficiaries. Any other questions? Otherwise, we'll close it. I want to say thank you very much. We may reach out to you and if we need anything, and certainly you're welcome to, send it to the B policy, it's a B.policy, B.policy at palmetto.gba.com.
Thank you.
Thank you very much.